Good afternoon. Welcome to the National Clinical Care Commission. I will welcome Linda Harris from ODPHP.
Hello, this is Linda Harris, the designated federal officer for the National Care Commission. I am pleased to welcome everyone to the sixth meeting of the Commission, and I will begin with a roll call of the members. Bill Herman.
Present.
Ann Albright.
Here.
I think we're getting some feedback. Howard Tracer.
Here.
Barry Marks.
Here.
Naomi Fulagawa.
Here.
Donald Shell.
Here.
Bill Chong.
Here.
Aaron Lapata.
Here.
Ann Bullock. Ann Bullock. Barbara Linder.
Here. Thank you.
David Wong. David Wong. Paul Conlon.
Here.
Ayatanda Sturlkman.
Here.
Carol Greenlee. Here. David Strogat.
Here.
Dean Schillinger. Ellen Leake. Ellen has told us ahead of time that she will not be unable to be here. Jasmine Gonzalvo.
Here.
John Boltry.
Here.
Meredith Hawkins.
Here.
Shannon Isaac.
Here.
Sherry Boland.
Here.
And Bill Cook.
Here.
And have Ann Bullock. Have you joined? David Wong.
Here. Here.
Dean Schillinger. Okay. All right, I'm going to now turn it over to our technical lead, Dr. Claudette Powell.
Thank you.
Sorry, we do have a quorum. Just wanted to announce that. All right, over to you, Claudette.
Thank you, Dr. Harris. It's a pleasure as the technical lead for the National Clinical Care Commission to share with you at this sixth meeting of the National Clinical Care Commission what we will be focusing on for today. Today's meeting is a result of reflection by the National Clinical Care Commission in their development of topic areas and relevant questions. So as you look through the agenda, you can see that we have quite a number of topics that focus on such things as health equities and disparities, Medicare coverage, durable medical equipment, the Diabetes Self-Management Education and Training Program, as well as the Medicare Diabetes Prevention Program. There are also topics related to virtual care and other means of delivering care about diabetes. And then later in the program, access to Part D drugs and formularies, and then some aspects of the transport, non-emergency transport, and the Medicaid course set. So for all these topics, we have 6 panels and quite a collection of panelists to share with you on these topics. I want to thank the Commission for their diligence in developing questions, and my especial acknowledgement to Drs. Barry Marks and Jean Stiller at CMS. Dr. Marks is the CMS representative to the Commission, and Dr. Stiller is the alternative representative, and both of them have worked closely with us in seeking out really a stellar and dedicated set of speakers for today. So I want to go ahead and just publicly thank them, and we'll look forward to jumping into those topics in one moment. What I'd like to do now is just to turn our attention briefly to the diabetes prevention and care model, which is the product of many weeks of substantive discussion by various members on the commission. The discussion began in earnest back in November when the model was first presented publicly. And at that meeting, which focused on the social determinants of health, there was a lot of discussion that expanded and built upon this model, which reflects elements of the chronic care model and the socio-ecologic model. So this is a unique deliverable, in a sense, of the diabetes prevention and care model. Now, we've had a lot of input into this, and at this time, I will just hand this over to Dr. Harris to solicit the votes and approval of the model.
Thank you, Dr. Powell. So the motion on the table is for the commission to approve of the model. I'm going to now conduct a roll call vote. Bill Herman?
Yes.
Ann Albright?
Yes.
Howard Tracer?
Approve.
Barry Marks?
Approve.
Naomi Fukugawa?
Yes, approved.
Donald Schell?
Approve.
Bill Chong?
Yes.
Aaron Lapata?
Approve.
Barbara Linder?
Approve.
Paul Conlon?
Approve.
Ayatunde Dukun?
Approve.
Carol Greentree?
Approve.
David Strogat?
Approve.
Jasmine Gonzalvo?
Approve.
John Boltrey?
Approve.
Meredith Hawkins?
Approve.
Shannon Isaac?
Approve.
Sherry Bowen?
Approve.
Bill Cook?
Approve.
Is there anyone whose name I did not call?
David Wong?
This is Ann Bullock.
Dean Schillinger?
Oh, good. All right. So, Ann, what is your vote?
Yes.
Okay. And David Wong? Your vote? David, are you there? Dean?
Approve.
All right. Anyone else whose name I did not call? All right. So the motion has passed, and I will now turn it over to Bill, who I believe will take it from here and transition to the main agenda.
Good, thank you. I want to just turn it over to Barry Marks, who again is our CMS representative to the National Clinical Care Commission. He will do the introductions of today's speakers.
All right, Bill, thank you very much. I'd like to thank the Commission for giving our presenters the opportunity to support this work by addressing its present transportation. So once again, I'd like to thank giving our presenters to support this work by information regarding best programs and policies. We'd like to introduce this afternoon about achieving health equity and the securities and James, Director of the.
Thank you so much. So on the slide, you're hopefully seeing our CMS Path to Equity, in which we talk about in our office and in the agency, we focus in our three parts of work, which is to increase our understanding and awareness of disparities and their causes, to work to develop and disseminate solutions, and then through ourselves and our partners, implement sustainable action. In our office, we focus on 4 priority populations, which include racial and ethnic minorities, sexual and gender minorities, people with disabilities, and rural communities. And if you go to the next slide, when we're talking about disparities and diabetes, as we look at the leading causes of death, and you can see that diabetes is not in the top 5 for the general population or for non-Hispanic whites, but it is in the top 5 for Black, Hispanic, American Indians, and Alaska Natives, as well as Asians and Pacific Islanders. And on the next slide, it shows you some of what we know about our disparities when we're talking about diabetes and prediabetes prevalence. And these data come from both the latest Health US statistics, which show the prevalence of diabetes in terms of those with physician-diagnosed diabetes is higher among African Americans and Hispanics, as well as those with undiagnosed diabetes. But as you know, we have large populations of individuals who have prediabetes and many who are not aware of it, including large disparities there that we see. On the next slide, within our office, some of the work that we have done to look at what's going on in varying populations. Each year we produce 2 stratified reports in Medicare Advantage looking at the HEDIS and CAHPS measures with regards to quality of care that's provided. And I'm not gonna, in the interest of time to try and catch up, I'll just go to the next slide to hit one of the highlights that we have in terms of our clinical care in diabetes that shows you when we're looking at blood sugar control that Asian Pacific Islanders have higher rates of actually having their blood sugar controlled compared to other populations, lower rates among African Americans and those who are Hispanic. And so we also know, similarly looking at rural and urban areas, rural areas are less likely to have their blood sugar controlled compared to urban areas, but within those areas we still see racial and ethnic disparities. On the next slide, we know that where you live matters, and this is one of our mapping Medicare disparities tools that shows you the prevalence of diabetes and how it varies across the country. This is for all populations, with those darker blue areas representing higher prevalence rates for other populations. And on the next slide, you can see how this compares by race if we look at Hispanic populations as well as white. You see, again, the reflection in our Medicare population, higher rates to the south and on the east, and for Hispanic populations, higher prevalence rates in those areas around Texas and over in the west in California. Also reflecting the geographic distribution of where these populations are. We know that more than half of the Hispanic population in the country lives primarily in 3 states, California, Texas, and Florida. On the next slide, you'll see that when we look at some of the other population groups that we focus on in our office, we have disparities for those who have intellectual and developmental disabilities with higher rates of multiple chronic conditions in terms of COPD, congestive heart failure, diabetes, hypertension, and obesity, but higher rates of diabetes in the population of individuals with developmental disabilities compared to those with no disabilities. And on the next slide, as we know, just most of our end-stage renal disease, a higher proportion of it resulting from diabetes compared to other conditions. And when we started, as we're getting on the cusp of launching Healthy People 2030, on the next slide, when we started Healthy People 2020, we had very racial and ethnic disparities within the incidence of ESRD due to diabetes. And we have not seen much progress in terms of the next slide, the reducing our kidney failure rate due to diabetes, having not attained our goal in several of our populations. And so we have work to do. And as we think about work to do and how do we manage diabetes in our populations, on the next slide, we wanted to show some of the work that we've done in looking at awareness and education of individuals and Medicare beneficiaries about what Medicare pays for in terms of some of the diabetes supplies. So this analysis, as we're showing, reports lower rates of awareness among Black and Hispanic Medicare beneficiaries about the knowledge that Medicare pays for diabetic testing supplies. But this analysis also found that our Black and Hispanic Medicare beneficiaries were diagnosed with diabetes at a younger age, at 57 compared to 60. Few of them had reported knowing everything that was necessary to manage their diabetes, and fewer of them reported knowing that Medicare helps pay for those supplies. So there's education awareness that needs to happen in addition to management and other pieces. And so as we go to the next slide, I'm sure you all are aware of the executive order priorities on advancing American kidney health from the president that came out earlier last year with a goal of reducing the risk of kidney failure, improving access and quality for person-centered treatment options, and increasing access to kidney transplants. And we're continuing to support those efforts and think about what we can do to slow the progression of chronic kidney disease, as well as reducing disparities in diabetes. And all of this kind of results in some of our negative health outcomes that we see. If you look on the next slide, where we have those who self-reported health status and the number of inpatient admissions for those with diabetes in our Medicare population, that we have very poor health being reported at a higher rate and obviously higher admissions. So what do we do about this? I think our colleagues are going to talk a lot about some of the other initiatives we have, so I'm just going to highlight a couple of the areas that we're engaged in. And one is on the next slide. Well, I'm sure you're all familiar with the Medicare Diabetes Prevention Program and the goal of that. And that's something that we've been working to support. And so with regards to that, on the next slide, what we can do to help make that a success is we think about making sure that we have MDPP suppliers and others who are participating in the National Diabetes Prevention Program who are working with vulnerable populations who are offering culturally, linguistically appropriate services, but also working with providers to make sure they're referring these individuals to the program and providing the supports that they need to successfully complete that. Also encouraging organizations in the community to get the CDC recognition and to continue adapting some of the materials to make sure that they are culturally, linguistically appropriate and relevant to the communities that they're serving. On the next slide, one of the other areas, so with regards to management and treatment of diabetes from a social context, and as we are learning more and more about the importance of the social determinants of health, and the model that you showed at the beginning, I think really reflects the context and the environment in which people are operating and living and working in their life. So I think one of the highlights that we wanted to think about is how we're supporting the collection and analysis of those data on the social determinants of health. I think we all recognize the importance of it, but we're not all necessarily talking about the same thing or measuring it in the same way. And as the ADA guidelines show for the support of that helping to address those contexts, the social context is critically important. I would also just note that as we are seeing from some of the recent work that's come out with regards to some of the algorithm bias, that as we're addressing the social context, we don't necessarily want to forget about the interplay between race and ethnicity and how that can also continue to see biases even after addressing some of these other issues or focusing on other things. So on the next slide, I just wanted to highlight, we've done some analysis of the ICD-10 Z codes. These are codes that capture information on social needs and social risk factors such as adverse childhood events, homelessness, problems of living alone, and other areas. And as you can see, for those beneficiaries, we've looked at our Medicare fee-for-service beneficiaries. Diabetes ranks as one of the top conditions for which we have Z code claims associated with it. I will note that this analysis indicated that very few of our beneficiaries have Z codes, which we do not believe means that they don't have social needs. We just feel that we and understand from our stakeholders and listening session that we've done that they're not being utilized and want to increase awareness and utilization of those. So on the next slide, one of the things that we've done in this area is to finalize some of the standardized collection of the social determinants of health, some of the social factors in our post-acute care setting, which will allow us to have that standardized data and to also look at the relationship between some of these factors and quality of care, resource utilization, and outcomes. And we sought comment on additional areas to include. And lastly, if you go to the next slide, I just want to highlight a couple of the resources that we have just put out in the last couple of months related to diabetes, including diabetes management directory of provider resources. This was developed talking to providers primary care providers, endocrinologists, and others related to what would be useful to them in helping to manage diabetes and reduce disparities specifically, as well as a resource guide of culturally and linguistically tailored type 2 diabetes prevention resources that includes a number of resources not only for racial and ethnic minorities, but also for persons with disabilities and other vulnerable populations. And then on the next slide, just continuing other resources with the quick guides from the Association of Diabetes and Education Specialists. And I think that collectively and working together, we can reduce disparities and continue to improve health outcomes for those with diabetes. Thank you.
Thank you. That was a terrific presentation. My question to you is, do you have a sense of, from a budgetary standpoint, what proportion of the CMS budget is dedicated to the Office of Minority Health? And within the Office of Minority Health, what percentage of the budget do you believe is dedicated towards diabetes and or prediabetes?
So I do not have that off the top of my head. I think that within the Office of Minority Health, I can say that the way our budget is organized, we don't focus a lot on disease-specific conditions. We work across all of the programs, and thinking about the way that the agency is organized, that's not necessarily how we align our budget, sort of which is different from other agencies like NIH or CDC. So I would have to do a little bit of research to figure out where our focus is in terms of what proportion of our budget is dedicated to that.
That would be great. Thank you. Because part of our charge is to make recommendations, and so it'd be nice to know the resources that the Office of Minority Health has to deal with the disparities you described.
Kara, this is Carol Greenlee. Thank you very much for that great presentation. Since our charge is to make recommendations, I'm really interested to know what you think for people with diabetes or prediabetes, the biggest thing we could recommend to CMS around that would reduce the disparities that your department is seeing in recording and following. What recommendation would you recommend to us to recommend?
I think that is an interesting question. I think that there are a couple of things that are probably within CMS's charge, and then there are probably some things that if CMS had additional, flexibility or authority from Congress that could help out. One, I think as we all know, the ability to address the social determinants of health is critically important. And there are some challenges with regards to our ability to do that in current programs, and that's not necessarily something we have the ability to do. I think we are trying within our flexibility through, supplemental programs that are available through the Medicare Advantage program or other opportunities through Medicaid and others to be able to address some of that. But it's hard to address a lifetime of challenges when someone turns 65 or before that. It's in that little bit of time. So I think that is one, and I think we all know the health outcomes is so much more associated with less of what's happening in the healthcare setting and more of what's happening outside of that. So I think that is one. I think another space within some of the disparities and thinking about what we have is there really is, as we've seen, a lack of awareness in terms of what is available for some of those resources. And I do think thinking about how we educate beneficiaries about the resources that are available to them and help to bridge and connect them to some of those is important. I would also note that we have seen in other disparities work that there is sometimes an information gulf and communication challenges with providers. So thinking about how we make sure that providers are communicating the information to beneficiaries in a way that is understandable and also equitable so that they know what is available can be helpful as well. And then I think the last thing I would say is that
as always, thinking about how do we make healthcare affordable for individuals within the social determinants of health. We know that our minority beneficiaries are more likely to be lower income, and so out-of-pocket cost sharing, which is not necessarily something we can always do anything about, also has implications for ability to adhere to treatment, to be able to purchase food, and to do the things that would help them remain healthy and reduce disparities.
Thank you.
And you mentioned a number, this is Bill Herman, thank you very much. You mentioned about making healthcare more affordable, reducing out-of-pocket costs, providers communicating better with beneficiaries, and increasing beneficiary awareness. Is that something that you would see being done primarily through your office, or what other federal agencies might assist with those tasks?
I think that we all have a role to play. I think that we, obviously, CMS have done beneficiary outreach for varying things, but I think that there are other agencies like CDC who do outreach awareness campaigns. HERS are working through the community health centers. I think it's multiple agencies who have an opportunity to reach people where they are, and through different channels that collectively we can magnify our impact, and including those in IHS and other spaces.
Good. Well, thank you very much, Dr. James. I guess I'll turn it back to Barry to move on.
All right, Bill, thank you again. Thanks to Dr. James, especially with our technical issues, which I told will resolve. Our next presentation is on Medicare coverage, durable medical equipment, and program integrity. And I'm pleased to introduce our speakers for this section, Joel Kaiser, Director of the Division of Durable Medical Equipment, Prosthetics, Orthotics, and Supplies, DNEPOS Policy, Beth Kohler in the Coverage and Analysis Group, and Jill Nicolaisen, Senior Technical Advisor in the Center for Program Integrity.
Thank you. This is Joel Kaiser. I'm the Director of the Division of MEPOS Policy at CMS, and we handle Medicare policy related to payment for durable medical equipment, as well as the scope of the durable medical equipment benefits. That is what items would fall in this category, the Medicare coverage category, and what items will not. Just briefly to give you an overview, the statute establishes the durable medical equipment benefit for equipment like wheelchairs, hospital beds, oxygen, for patients for use in their home. Over the years, we've covered under the durable medical equipment benefit some equipment specifically related to diabetes care. So now, close to 4 years, we've been covering blood glucose monitors under the DME benefit. About 25 years, we've been covering insulin infusion pumps under the DME benefit. And now, for about 3 years, we've been covering certain continuous glucose monitors under the DME benefit. So an item, in order to be paid under the DME benefit, an item must be durable, must be something that can be rented, withstand repeated use, must be medical in nature, must be appropriate for use in the home by the patient. There was a question about replacement of DME. Medicare payment rules for DME originally were rental. In 1989, we started paying for the rental of items, but capping the rentals at a certain period. And we also pay for certain items on a lump sum purchase basis, like glucose monitors. The statute specifically mandates that we limit payments for expensive items like insulin pumps to 13 rental months. After the 13th rental month, the beneficiary takes over ownership of the item. Then we don't pay again until that item has to be replaced. Statute mandates a replace the lifetime of 5 years. So after 5 years, we can then pay for the replacement of those items. That's a statutory requirement. So that's a quick overview of the benefits.
Yes, in my presentation, I hope to address your information needs. In this section, the following will be addressed: Medicare coverage policy processes, the Medicare population diabetes, glucose meters and strips, continuous glucose monitoring, devices, subcutaneous insulin infusion pumps, and closed loop systems. In a later session, diabetes self-management training and medical nutrition therapy will be addressed. My slides describe expectations and the authority. Slide 1, Medicare is a federal program and it's a defined benefit program. It serves a specific set of population. First is the community dwelling population in which there is eligibility by disability. First, you have to qualify by community and then by Medicare. Then there's eligibility by age, being older than 64. Lastly, there is eligibility by disability and age. There's also a non-community dwelling population that resides in nursing homes. This aggregate population is not the same as that addressed by Medicaid, which consists of state-federal partnerships and is composed of several populations. As such, the Medicare populations are not the same as the population at large. The statutory authority for Medicare is based on whether it is reasonable and necessary to pay for the items or services to diagnose or to treat illness or injury or to improve the function of a malformed body member for Medicare benefits. The mission and authority of Medicare differs from that of the FDA. Next slide. Medicare has several distinct parts. Part A, part of traditional Medicare service, addresses surgical charges and some hospital charges. Part B, also fee-for-service, addresses outpatient charges and provider charges. Part C is the Advantage plans, the commercial HMO and PPO plans. They operate under different rules. Part D involves the prescription drug plans, also commercial plans. Part C drugs, which are usually parenteral and not self-administered, are different. Slide C. The coverage and analysis tag in the Center for Clinical Standards and Quality in the Centers for Medicare and Medicaid Services has established processes for making coverage determinations and reconsidering coverage decisions. There are similar processes for the local contractors. There are different types of local contractors, including those for Parts A and B and durable medical equipment. National coverage determinations, NCCC, are binding on all jurisdictions. Local coverage determinations may vary by jurisdiction. Slide 4. Coverage decisions reflect both an evidentiary base and whether the item or service has a benefit category as determined by Congress and the Center for Medicare. Coverage decisions for durable medical equipment are based on the Center for Medicare definition of DME. On the other hand, prevention and screening benefit coverage, when it's determined by tag and not by statute, that requires an NCCC. The authorization for such screening and prevention services came by the Medicare Improvement to Patients and Providers Act 2008, NIPA. The regulatory authorization for such additional preventive services came via Federal Register Notice 42 CFR 410.64. The process requires that a U.S. Preventive Service Task Force recommendation have a grade of A or B. However, the evidence must also meet certain other requirements, including the applicability to the Medicare population. Now, when looking at the demographic of those who have diabetes, in the general population, the proportion of those with type 1 is about 10%. Those with type 2, about 10% of those with diabetes. By contrast, in the Medicare population, the portion of those with type 1 is smaller at about 5%. Younger patients with type 1 diabetes who qualify for Medicare usually do so on the basis of disability, either from diabetes complications or from other comorbid diseases. Diabetes alone is not a qualifying condition. Next slide. TAG is very interested in various complications associated with diabetes. In type 1, glycemic control may prevent microvascular. By contrast, in type 2, the underlying macrovascular disease is often present prior to hypoglycemia. Glycemic control with insulin does not mitigate macrovascular risk for disease, and glycemic control may not mitigate aspects of retinopathy, nephropathy, or peripheral neuropathy, and this is somewhat different than in type 1. Next slide. And it is understood that patients may have mixed disease with insulinemia. Indeed, some patients with type 2 may act more like those who have type 1, and such data inform our decision. Next slide, slide 7, is insulin pump. The Medicare benefit for substitute insulin infusion pumps includes a DME qualifying pump supply, and insulin, a medication that is not otherwise provided under Part B. Patients who use the Medicare or need a pump must meet clinical requirements consistent with suboptimal control, despite comprehensive diabetes education, use of at least 3 daily insulin injections with a demonstrated ability to adjust doses, and document 4 times daily glucose testing. This establishes the clinical benefits to be derived from the intervention of the insulin pump. Suboptimal control is defined as having severe glycemic excursions, wide preprandial glucose variation, marked on phenomenon hyperglycemia, elevated hemoglobin A1C levels, and or recurrent hypoglycemia. All patients must demonstrate the risk for insulinemia or the presence of insulinemia, but they only need to do this one time. They do this via demonstration of positive beta cell autoantibodies or low endogenous insulin levels by peptide levels measured in the absence of confounding glucose toxicity and with adjustments for creatinine clearance. As such, the benefit is not limited to patients with type 1 diabetes. Next slide. Professional use continuous glucose monitors, CGM, to identify problems with short-term surveillance are covered as per our local contractor. Personal adjunctive CGMs that provide tracking and trending information are not covered by Medicare. Non-adjunctive, and they term them therapeutic CGMs that could meet the criteria for DME and have been labeled by the FDA as being able to be used to make treatment decisions without the need to stand-alone home glucose monitors to confirm testing results are covered for the local DME contractor. Specific brands are not detailed. Non-adjunctive therapeutic CGMs that don't meet the criteria for DME may not have a benefit category. Non-adjunctive therapeutic CGM, the benefit includes an allowance of consumables, including batteries, calibration supplies, sensors, and transmitters, in addition to the DME device itself. For coverage of the non-adjunctive therapeutic CGM, beneficiaries with diabetes must have a treatment regimen that requires frequent adjustment of insulin by the beneficiary based on glucose meter readings or interstitial glucose CGM readings. They must have been using a blood glucose meter and performing glucose testing at least 4 times daily. And they must be using at least 3 insulin injections daily or using a Medicare DME continuous insulin infusion pump. The treating provider also has to do certain things. They must have seen the patient in person within 6 months prior to CGM prescription and have determined and documented that the 4 criteria have been met. This must be repeated at 6 months into the rationale for glucose assessment 4 times daily is that information from the CGM is intended to inform patients' decision making. Bolus or short-acting insulin dosing usually occurs prior to meals, so 3 daily measurements, and basal insulin is assessed prior to the first meal and at bedtime. That would be number 4. Medicare often requires documentation to assess utilization and response for rental items and devices with continued expenditures. Other examples of this are like CPAP, continuous positive airway pressure policies that we have. You can see a link for that. The next slide. Medicare provides a beneficiary with home, not professional glucose meters. The benefit initially was for those with type 1 diabetes, and this was later expanded to those with type 2. And NCCC addresses the meters, but the local DME contractors address documentation requirements for meters, test strips, Lancet, and Lancet devices, and calibration solutions. Next slide. For the purposes of DME, the description of physician has been expansive and included other providers. Now, there are requirements for meters. Obviously, the beneficiary has to been diagnosed with diabetes. The device is designed for home use rather than clinical use. The beneficiary provider needs to document that the patient is capable of being trained to use the particular device prescribed in an appropriate manner, or that a responsible individual can be trained to the same to ensure that the intended effect is achieved. Now, there are special readers for those with visual impairment or manual dexterity problems. These require additional documentation. And there are requirements for the supplies. The number of strips and lancets is based on whether insulin is used or not. And for high utilization patients, those who are using more than 300 strips and or lancets per month, particular beneficiary needs and documentation requirements apply. Every 6 months, the beneficiary's glycemic control and testing must be verified, and the specific amount of excess utilization supplies must be determined. Now, the DME contractors have relatively uniform requirements, and on our query of them, they reported that there have not been significant numbers of these denials. The last device in the various Lancet devices, and they may be issued every 6 months. There are required elements for ordering: beneficiary name, testing frequency, exact items to be sent, order date, the provider signature date, and the provider signature. The way to document high utilization needs include a copy of the test log, lab results, documentation, medication changes, or particular symptom management, or specific narratives from the record. Next slide. So DME suppliers are not supposed to send glucose monitoring supplies in excess of the documentation provided. A major cause of comprehensive error rate testing for CERT program errors is supply dispensing that is not supported by the provided documentation. You should know that the Office of the Inspector General regularly conducts audits in this area. Next slide. CMS has an old policy for inpatient closed-loop systems for short-term stabilization of patients with type 1 diabetes during periods of stress. For those of you of a certain age, you will know that the bias matter, which was also used for glucose clamps, is one of these devices. CMS is aware of the FDA guidance on the artificial pancreas, the use of interoperable automated insulin dosing controller devices and software as used by the Brown Group in a recent 2019 publication. And that's the end of my presentation for this section.
Jill, are you on the line?
Yes, I am.
Please.
This is Jill Nicolaisen from the Center for Program Integrity at CMS. And I was asked to give you a little bit of information about our program integrity activities. So the Center for Program Integrity develops strategies and oversees the program integrity efforts for our Medicare and Medicaid programs. I work with mainly the original Medicare program, and so what I'm discussing today really relates to that, but there are similar strategies and activities in Medicare Advantage, Medicaid, and the Part D drug benefit. So our primary objective is to detect and prevent improper payments. And we really strive to strike a very important balance between protecting beneficiary access to covered health care and reducing the administrative burden on legitimate providers and suppliers, while at the same time ensuring the taxpayer dollars are not lost to fraud, waste, and abuse. So to say it simply, our focus is on paying it right. That is to pay the right amount to the legitimate providers for covered, reasonable, and necessary services that are provided to eligible beneficiaries. So while we in CMS oversee the program integrity efforts and strategies to prevent improper payments, we contract with entities who do the actual audits. Some improper payments are intentional, that is, claims for payments from entities who are attempting to defraud the government. And to do those types of potential fraud investigations, we contract with Unified Program Integrity Contractors, or UPICs, you may have heard. And their investigations can lead to referrals for law enforcement or administrative actions, such as payment suspension or revocations, that is, revoking a provider's billing privileges. And then the other type of improper payments are just purely mistakes. That is, legitimate providers who may not understand Medicare coverage policies or billing rules. And we contract with Medicare administrative contractors recovery audit contractors and some other specialty medical review contractors to focus on this type of improper payment. Of course, we can't look at every claim that is submitted to make sure that it's proper. So all of our contractors have to conduct data analysis, so they're really focusing their effort on providers and claims that are most likely to be at risk for improper payment. So most program integrity audits include medical review. That's the clinical review of claims and the associated medical records to assess whether coverage policies and billing rules are met. It's not enough to simply have an order. The medical record has to include the documentation to support that the item or service was medically necessary in accordance with all of the Medicare policies. You just heard Dr. Kohler talk about many of those policies. Medical review can be conducted on a prepay basis, that's before a claim is paid, or on post-pay after the claim has been paid. We carry out our program integrity activities under the statutory requirements in the Social Security Act that Medicare payments may not be made for items or services that are not reasonable or necessary, and unless there's been furnished such information that is necessary to determine the amount. We think it's important. I mentioned that we could do medical review on a prepay or a post-pay, but we think it's really important to prevent improper payments from occurring in the first place. And so many of our medical review is conducted on a prepay basis so that we can assure the claim is proper before paying it instead of having to recover payment if it's later determined to be improper. But we really think that education is key to correcting errors, and we and our contractors do this in a number of ways, including educational material that's posted on our website. We do webinars and hold meetings with providers such as provider focus groups. And then we also changed the way that our MACs conduct medical review. We've transitioned to a program that we call Targeted Program Educate, TPE for short. So TPE better targets medical review, and it limits the number of claims that are reviewed for a provider. And we really put an emphasis on the one-on-one education after a review to assist providers in correcting their claims errors. So I think the last point that I want to make is that program integrity does not make coverage policies. Instead, we look during our program integrity activities to ensure that there's documentation to support that the policies that are in place are met. We look at things like national policies such as requirements in the Social Security Act, the Code of Federal Regulations, the NCD that Dr. Kohler mentioned, our manuals, and the local coverage determinations that are developed by the MAC. So I think in other words, what I would say is the documentation requirements for specific items and services are really driven by the coding coverage and the billing rules that are in place. So I'm going to stop here. That is pretty high level overview, but I'm happy to answer any questions.
Great, thank you. Those were three really nice presentations. Are there questions now? I guess this is Bill Herman. I guess I had a question for Dr. Kohler, and that relates to the coverage policies. Some of those are statutory, I guess, but there's a committee as well that makes those decisions. And what is the process, and how can those coverage decisions be influenced or changed?
Well, the links that I provided to you actually is CFR notice, and it actually tells people exactly what the coverage process is all about and what people need to do. And that would be under slide number 3, Federal Register, volume 78, number 152, Wednesday, August 7th, 2013 notices. And then below that, we actually have an index, and it provides some similar information there, and step by step what you need to do.
Is that pretty straightforward, and how feasible is it to get policies changed?
Well, I guess that's a little bit in the eyes of the beholder, but it's a straightforward process, and it's codified in regulation, so it's pretty well laid out as to what needs to be done. Because our decisions are based on evidence, there needs to be new evidence in order to change a prior policy.
Okay. And I'm sure you've heard of some of these issues, but the coverage is 5 years for a pump through Medicare. The warranties by the manufacturers are 4 years, so there's a year when patients are potentially liable or can't get their pump repaired. And the CGM issue, monitoring 4 times a day, CGM is being increasingly prescribed for patients who don't or can't monitor. And so the requirement that you monitor to get a device that permits you not to monitor seems counterintuitive. Do you have any thoughts on either of those?
Well, the first question is not a coverage question, it's a question for CM to answer. The other question is needs to be an evidentiary basis for that, and there may be some other aspects of policy that impinge on that. So I'll turn that, I don't know if Joel could answer that question or not.
That was the requirement to monitor 4 times a day to be eligible for CGM, which then requires you not to monitor at all.
Here's Joel responding to the first question, the differential between the 5-year useful life and the potential for the 4-year one.
Yeah, so this is a benefit for durable medical equipment, and Medicare defines durable medical equipment as equipment that can withstand repeated use. So it's equipment that lasts. What the statute did in the early 90s was it created a 5-year reasonable useful lifetime for cash rental DME. We expanded that requirement to all DME, but it basically is a replacement parameter that durable medical equipment is supposed to be durable, it's supposed to last, in this case for a minimum of 5 years, and so that's something that was set forth in the statute. We could, if we have reason to believe that we should change the reasonable lifetime for certain items, we could do that. We have authority to do that. I don't know if warranty of 4 years means that the item only lasts for 4 years. I know it's a warranty of 4 years, but whether or not the item lasts 4 years is a different question. If the manufacturers make the product so that they only last 4 years, and that's the planned obsolescence, versus maybe, 25 years ago when we started covering insulin pumps, they might have lasted 5 years or longer. So that's really an issue regarding, a change in manufacturing practices and a change in quality. And if that, is something that happened, then we might want to consider rulemaking to adjust the fee schedule amounts accordingly to reflect the shorter lifespan. But to change the replacement frequency, that's something we would have to, we do have the authority to do, but we'd have to have some kind of evidence to allow us to say that, hey, insulin pumps, for example, the lifetime is really 4 years. And so we're gonna reduce the lifetime and the replacement frequency from 5 years to 4 years. And like I said, that might also, we might also want to consider lowering the fee. So, if we also have evidence that they used to last longer. So that's basically my response to that.
Thank you. Other questions?
This is Carol Greenlee. I am just curious, the requirement to provide the same documentation over and over again every 6 months on the test strips when diabetes, except in rare situations, is an incurable lifelong condition once it starts, that 6-month window seems very small for the duration of diabetes that most people will have it unless they get a pancreas transplant or something. So is that CMS rulemaking that put that at 6 months, or is that something that requires a change in some law or act, that 6-month requirement?
Well, there are specific requirements that are more rigorous if you want more than 300 strips or lab tests per month. The exact requirements, what should be done is these are addressed by the local contractors, and they have policies for this, and these policies, they will state the evidence behind the policy. So in this case, one should consult the Union MAC in your region.
And does CMS have any guiding policies for the local contractors, the MACs, et cetera, or they just determine independently?
Well, there are national coverage determinations that are binding on all jurisdictions, and when it comes to local coverage decisions, they have a parallel review process. They go through an evidentiary process,
and they developed a policy. What was provided in the link was an example of one of these policies from, I believe it was from Meridian, and that guides you through their how they make their decisions on this particular topic.
This is Jill, and I would just add, and certainly I would defer to the DME Max who created the LCD. But I think the providing documentation every 6 months was for the high utilization, and I believe that at present day the thinking behind that was that typically when patients are brittle, they may need to test more frequently, but then once they sort of settle down, that they may not need to test at that high frequency. So I think that that requirement for every 6 month documentation is really only for the high utilization.
And Jill, this is Bill Herman. To follow up on that, I think you outlined the issue of balancing access to care with provider burden and minimizing fraud and abuse. But have you ever rigorously looked to see if increasing the requirements for test strips inappropriately reduces utilization? I mean, you can minimize fraud, but there may be people who are not testing or not testing as frequently as they maybe optimally should. Has that been looked at?
I can say we have specifically looked in detail at that, but when we work as an agency across the agency, like I said, in program integrity, we really only enforce the requirements that are there, but we do work with others across the agency who develop policies to think about, are there some changes that could or should be made? So certainly this is a good suggestion for us to take back.
Hi, this is Bill Cook. One of our frustrations in primary care is the redundancy of all this documentation that's required. Practically everything that's on those forms that we fill out every 6 months is right in the medical record, and we're basically just copying it onto a piece of paper and faxing it involving multiple members of our staffs, et cetera. Is there any attempt at all by CMS to try to have some portal into records to just extract this information rather than making us just redundantly keep telling you in multiple forms the same thing?
I can tell you that yes, there are some initiatives going on to work on, especially with electronic medical records. I'm not the person who can tell you a whole lot about them. I think we could probably have someone provide more information in the future, specifically on that if you're interested. But I can tell you it's something that is being thought about and considered.
Just sort of for the benefit of the rest of the commission, that's, when you talk about taking good care of patients, you don't do that as effectively as if you don't take good care of the providers too. And probably recommendations to do this sort of a thing that minimizes this redundant documentation that's required of us is something that ought to be etched in somewhere with our recommendations.
Great. Well, I thank the speakers. Barry, I'll turn it back over to you.
Bill, thank you very much. The next session is on diabetes self-management, education, and training, virtual care, and other provider types delivering diabetes care. The presenters for this session are Jennifer Lloyd, Beth Kohler, Gift T, the Director of the Division of Practitioner Services, and Emily Yoder with the Hospital and Ambulatory Payment Group. And first, Dr. Lloyd.
Thanks, Barry. Hi, my name is Jennifer Lloyd. I work in the Innovation Center within CMS. I don't work in the Center for Medicare, as many of the other presenters will be coming from that group. So at the Innovation Center, we get to work on our own research, and some of the research projects we were interested in is looking at the diabetes self-management training benefit. And so I believe you received the 2 research articles that were shared ahead of time. And so I'm going to go through those results at a high level. I do want to provide this disclaimer. As I had mentioned, this research project was undertaken through individual interests of mine and the other co-authors. It was not conducted under official direction of the agency, and the findings do not reflect the official position of CMS. So to start with a little bit of background, the DSMT program uses an evidence-based curriculum to target patients' skills and knowledge about diabetes. So nutrition, exercise, medication management, foot care procedures, and monitoring glucose levels. And this is to promote effective self-management of their condition and hopefully prevent diabetes complications. Patients are eligible to receive this benefit if they're diagnosed with diabetes in the last year, if they are taking medicine or insulin related to diabetes, if they were considered at risk for diabetes-related complications, or if they had diabetes when they became eligible for Medicare. Patients can be referred to this benefit through a certified provider for up to 10 hours of the training in the initial year and 2 hours in subsequent years. However, there is only allowed there's individual and group trainings, and so they're only allowed 1 hour of individual training and 9 hours of group sessions. So that's how the 10 hours within the initial year gets broken up. So moving on to some of the results. In the first paper, which was published in 2015, we focused on describing factors associated with DSMT use. The data from that study is looking at the 2010 year, and we pulled a random sample of Medicare fee-for-service beneficiaries. So these are individuals not in Medicare Advantage, and these individuals had to be continuously enrolled, which means they had to have kind of consistent month-to-month coverage of A and B services, and so that limits our sample a little bit in terms of the entire Medicare population. We also limited our sample to newly diagnosed beneficiaries, people who had just been diagnosed with diabetes, as that kind of replicated one of the eligibility criteria for the benefit, and it's difficult to replicate some of that other criteria in claims-based analyses. We searched Medicare claims data in that same 2010 year for either the individual or the group codes of DSMT services, and each of those represents a 30-minute service. Moving into the results, among the beneficiaries that were newly diagnosed with diabetes, we saw that about 5% of those individuals had used either the individual or the group DSMT sessions.
I'm sorry to interrupt. Are the slides supposed to be going along with your talk?
I don't have any slides.
Oh, okay.
So
sorry.
if you... That's okay. We did send those 2 papers out ahead of time if you would like to look at some of the figures or tables. So going back to the mean count of how many actual kind of codes or services individuals received, the mean was a little bit under 3 training sessions. So these individuals had, roughly 1.5 hours of the DSMT services on average. Looking at the use of the group versus the individual codes, we saw that the majority of the billed codes were for the group sessions. So almost 60% of the billing was for group sessions, and the remainder was for the individual training sessions. In terms of the characteristics we saw that were associated with DSMT use, we found that a number of characteristics were associated with lower use. So for example, men, individuals who are younger or disabled, or in like the older age groups, the much older age groups, minorities, individuals who are dually eligible for Medicare and Medicaid, as well as individuals with other comorbidities, specifically Alzheimer's and dementia. They had lower odds of using DSMT services. And many of these really, in our view, reflect broader health disparities among vulnerable populations that we've seen among the diabetes, in general, among diabetes healthcare utilization, and a lack of access to a usual source of care, lower preventive healthcare utilization. And so some of that really is just in line with broader health disparities in our view. We also found higher odds of DSMT use were associated with the concentration of providers that were offering services in a given county, as well as among specific census regions. We noted in the discussion some potential reasons for the low utilization among these newly diagnosed beneficiaries, including the possibility of patient and providers being unaware of the benefit. There's also a number of unmeasured factors from both the patient and provider perspective that we weren't able to address in our methodology, and these could be biasing our study results. So for example, patient characteristics such as functional status, health literacy, and general proclivity of using other healthy preventive services or participating in other healthy behaviors. Those are typically, can create a lot of issues in study methodologies and make results appear biased because we can't capture all those factors in especially claims-based analyses. Other factors could include providers' perception of the burden to become accredited to bill for DSMT services, which we saw in prior literature. There's also a number of other factors in terms of providers' use of shared decision-making tools, their cultural competency, and general referral patterns to other preventive and disease management services that could be kind of in the background biasing our results. Indeed, in survey data, which we used from the Medicare Current Beneficiary Survey, we saw that close to a third of Medicare beneficiaries with diabetes reported attending a diabetes management class, not necessarily the DSMT training benefit. And this suggests that utilization of disease management training programs and potentially DSMT might be happening with more regularity than the claims analyses were really able to capture in that first paper. Moving on to the results from the second paper, which was published in 2017, we examined the effect of DSMT utilization on subsequent healthcare use. So there already was a substantial evidence base on the short-term benefits of DSMT. Many studies have already shown that DSMT improves patients' knowledge, accuracy of self-monitoring of blood glucose and cholesterol screenings, and dietary habits. Studies have also found that DSMT improves clinical outcomes such as HbA1c levels, lipid and blood pressure, medication use, the list goes on. So to our knowledge, though, however, we did not believe there was any other studies on the longer term impacts of healthcare utilization from the benefits. So using a similar approach as we had done with the prior paper, we used a 20% random sample of Medicare beneficiaries who were newly diagnosed with diabetes, again, thinking that DSMT might have its maximum impact on someone who's newly diagnosed potentially. And we looked at a little bit longer time window than the prior study. So for this second study, we looked at individuals who used DSMT between 2009 and 2011 to have a little bit more sample size to look at outcomes. And we followed individuals that had used the service in that time window for 12 months after they were initially diagnosed with diabetes to see, what would happen in terms of their hospital-related utilization and total Medicare expenditures. And so this paper found that among this sample, about 8% of the newly diagnosed beneficiaries had used a DSMT service at least once within the 6 months after their initial diagnosis. And there was a high utilization rate right after that initial diagnosis, and within that 6-month time window, about 93% of these beneficiaries used the benefit shortly after they were diagnosed with diabetes. And similar to the prior paper, we found that the majority of the sample used only about 1 or 2 sessions, so it's a little bit lower than the prior sample, but between a half an hour and an hour's worth of the service. For this study, we constructed a comparison group of Medicare beneficiaries that were similar to DSMT users on a range of characteristics that we were able to capture in claims data. Again, that can be very limited. We used a couple of different statistical analyses to try and attempt to control for factors that might bias study results. So that would include the healthy adherer effect, which is something that's known to plague preventive services research and health services research. So we followed a number of the kind of typical processes that are done, including propensity score matching, to try and get really good matches of the comparison group to the intervention group. And moving into the study results, we found that DSMT users had a 14% reduced odds of any hospitalization within that follow-up year. And so that was any hospitalization. It could happen once, it could happen 10 times. We kind of don't differentiate for that measure. For looking at the number of hospitalizations, which we also examined, we saw that DSMT users had a much lower number of hospitalizations as well, with approximately 3 fewer hospitalizations per 100 individuals. The number of emergency department visits was also lower, 6% lower among DSMT users, which equates to approximately 3 fewer emergency department visits per 100 individuals. Other utilization measures showed promising reductions, but were not statistically significant. For example, the diabetes ambulatory care sensitive conditions, which we thought would be a very relevant outcome measure. It ended up that these events are just very rare in the sample that we pulled, individuals who are newly diagnosed with diabetes, and so that could be driving the fact that it wasn't statistically significant. Again, the direction of the result was in the expected direction of lowering that utilization. And finally, in terms of the impact on Medicare spending, we saw a reduction in total Medicare Parts A and B expenditures of $830 per DSMT user, and this is relative to a propensity score matched comparison group of non-users, so fairly rigorous comparison group. We looked at a number of different sensitivity analyses to see if these effects would hold, and among the majority of the sensitivity analyses we did, including looking at a dose effect. So if multiple DSMT sessions had a larger effect or a different effect, and those results were all very similar to what were presented in the paper. However, there are a number of caveats that should be mentioned in light of several study limitations. So first, as is stated in the paper, consideration should be given to the remarkably strong, lasting impact of a relatively brief intervention. And so we're just, study biases could still be driving the study results, and we want to make sure that caveat is brought forward and is clear. As previously mentioned, the number of unmeasured factors could be driving these results, and it's just kind of hard to say how much that might be happening. For example, the effect may be partially driven by the fact that these DSMT trainers and providers are essentially high quality providers. And so the patients in our intervention group are already seeing kind of the cream of the crop in terms of provider types. These individuals have to become accredited in this evidence-based curriculum, and they're subject to compliance of monitoring from that program over time. And so you would imagine that that could result in higher quality of care that this intervention group was receiving, and that alone could bias study results. Even with a number of methodological attempts to control for these factors, results still may be biased. We also want to make sure it's understood that the results that we put out are limited to the fee-for-service population, so they're not applicable to the managed care side of Medicare, and that is increasingly representing larger proportions of the Medicare population. I think we're at 30 to 40%, kind of increasing over time, and so just kind of keep that in the back of your mind that the fee-for-service population is different. And then also that we looked at newly diagnosed beneficiaries, people who had just been diagnosed with diabetes. And so there were other eligibility criteria that we did not examine, such as individuals who've had diabetes prior to entering Medicare and they're new to Medicare, and so then they can receive that benefit. And so the results are just not applicable to the other types of beneficiaries that could receive the benefit. However, given these limitations, we believe the findings confirm results from prior studies showing the benefits of patient activation programs, use of preventive services, and adherence to self-management programs. And particularly in light of the fact that the cost for the DSMT service itself is fairly low, with $14 for the group sessions and $53 payment rate for the individual training session. That was as of 2015. It's probably a little higher now. And so even at the max amount that could be billed in a year, which would be a little over $350, And given the return that we think we're seeing in this data of savings around $800, there seems to be room for substantial return on investment from this program. I think that's it for me. But with that, I'll turn it back to Barry.
And okay.
Okay, I'm going to be actually discussing two programs that have some degree of overlap. I'm talking about diabetes self-management training and medical nutrition therapy. Now, the outpatient educational and training services provided under diabetes self-management, DSMT, include self-injection of anti-diabetic drugs. During the first year, there's up to 1 hour of individual training and 9 hours of group training. In subsequent years, there's up to 2 years of follow-up training. Telemedicine may be used in rural areas under select conditions. Now, medical nutrition therapy can also be received by the patient, but not on the same day and must be provided by a qualified nutrition specialist. Eligible beneficiaries include those with new onset diabetes, hemoglobin A1C repeatedly over 8.5% units, a change in treatment regimen from no medications to diabetic medications, or a change from oral medications to insulin, or other risk factors from various complications. Patients in the hospital, hospice care, skilled nursing facility, or a nursing home are not covered. Any such services provided are included in the facility fees. The Balanced Budget Act of 1997, I know this might seem a little arcane, but you have to understand where all of these things come from, authorized DSMT. And it required a certified provider for DSMT services, as well as physician certification of the need for DSMT. This latter aspect was modified by regulation. An amended section of the Social Security Act, Section 1861 gave CMS the authority to regulate DSMT as provided to Medicare beneficiaries in the outpatient setting. And certification can be obtained by an individual or by a group program. The American Diabetes Association and the Indian Health Service certify groups. The American Association of Diabetes Educators, and I know that they have a new name, certify individuals. Programs must meet standards established by the National Diabetes Advisory Board, or the entities that followed afterwards. Approved entities that bill under DSMT coding must collect and record at least quarterly and in an organized, systematic manner patient assessment information. Diabetes education provided and billed as a higher level clinical visit, as an extended clinical visit, or as a consultation that is not billed as DSMT. These things these forms of education do not appear in the administrative claims data. And so you have to basically be a certified provider to bill that way. The education may be provided, but cannot be billed that way, and therefore will not show up in the administrative claims data. And indeed, even in the original Federal Registry notice, this type of non-billable DSMT education was acknowledged. So now we'll move to the next slide, next and last slide, to medical nutrition therapy, MNT. It provides nutritional assessments and interventions consistent with nationally accepted dietary or nutritional protocols for those with diabetes or renal disease, not yet requiring dialysis, or within 36 months after a renal transplant. Initially, the benefit provides 3 hours of MMT alone, but there's a little caveat here. The MMT and DSMT hours combined may not exceed the maximum hours covered by DSMT during the first year. And in subsequent years, beneficiaries may receive 2 years of MMT alone. And again, there's the issue of MMT and DSMT hours when they're combined cannot exceed the maximum hours covered by DSMT for follow-up training each year. Again, there are some exceptions. Face-to-face service is required except under special circumstances. And the service requires referral by the treating physician. And the MMT authorization came from the Medicare, Medicaid, and S-CHIP Benefits Improvement Act of 2000, HIPAA. And it actually explains where all these rules came from. That's why all these citations were provided. And it defines the scope of the services and the provider qualifications. And we have additional information, but I think that that's enough to give you the skeleton of it.
Thank you, Beth. Git, are you on the line?
I am, Barry.
Please go ahead.
Yeah, thanks, Beth, for that overview. I don't have much to add to that. Just wanted to touch on some of the payment aspects of DSMT. There are currently 2 codes under the PFS that are paid. One for self-management training for an individual for 30 minutes, and the second for group, 2 or more for 30 minutes. Typically, we expect, well, not typically, but we expect that the services be provided by a certified provider, i.e. a physician or other individual entity that in addition to providing DSMT also provides other items or services. We also expect that certified provider is certified by the ADA or AADA, ADE. In that case, there are other providers certainly that could furnish these services, including pharmacies. Just looking through our data, we see that there are definitely services that are submitted on claims by pharmacies. I just wanted to also level set, just to hammer home concepts that I think I heard Beth touch on. There's certainly a distinction between what is statutorily defined versus what is regulatory defined, and we certainly take those into account as we establish payment for these services. That's all I was going to cover, Barry.
All right, thank you, Git. Emily?
Yes, so I am going to provide an overview of sort of the virtual care space for Medicare telehealth and what we call communication technology-based services, which are services that utilize telecommunications technology but are not part of the Medicare telehealth benefit. So the Medicare telehealth benefit is a statutory benefit and it is over 20 years old. It was established to help promote access to care in rural areas. As such, there are numerous restrictions for when the patient must be located in a rural area, in a healthcare facility, so not in their home, which is something we hear about frequently as a barrier to utilization. And the distance site practitioner is limited to certain types of healthcare practitioners. When these conditions are met, the telehealth service is paid as though it occurred in person, which is very important because overall the physician fee schedule, which is the fee schedule by which Medicare telehealth, is paid under, is a resource-based payment system. So what this means is while there are certain efficiencies that are associated with performing a service virtually, and under normal PFS policy, we would actually account for those efficiencies in the payment rate. When all of the restrictions for Medicare telehealth are met, it essentially just carves out those services from the normal sort of requirement that the PFS be paid based on the relative resource cost of furnishing a service. So MNT has been on the Medicare telehealth list since 2006, and DSMT has been on the list since 2011. In both instances, we also revised our regulations to specify that for MNT and DSMT, practitioners such as nutritionists or PAs and NPs who normally are not eligible to furnish Medicare telehealth services independently can perform those services, but only for the purposes of these MNT and DSMT under Medicare telehealth. Overall, in terms of utilization, because of the restrictions, overall utilization for telehealth is relatively low. For example, in 2018, total telehealth utilization, and there are around 100 services on the Medicare telehealth list, was around $500,000. 500,000 services for about $35 million, and this is out of a $90 billion payment system, so it's a very small chunk of overall PFS spending. And I know that this seems like very, very limited utilization, but remember, Medicare telehealth is not about incentivizing application of telecommunications technology, but instead about incentivizing practitioners to perform care for beneficiaries who are in rural areas. We frequently get requests to amend various aspects of Medicare telehealth, such as allowing the patient's home to be an eligible originating site. But unfortunately, because this is a statutory benefit, we have no leeway to amend these restrictions. What we can do, however, is make payment for physician services that utilize telecommunications technology and take into account those resource costs. So that leads me to the sort of second set of virtual services, which is the communication technology-based service. So Medicare already makes payment for services furnished via telecommunications technology, such as remote interpretation of diagnostic tests or certain portions of care management services, such as chronic care management. However, in 2019, in an effort to begin modernizing Medicare payment for services that utilize communication technology, we began making payment for the set of services that we call communication technology-based services. These are services that are explicitly defined as taking place via communication technology and are valued to account for the resource costs associated with remote services and are not subject, therefore, to the Medicare telehealth restrictions. So in 2019, as part of that push, we finalized what we call a virtual check-in and a remote asynchronous services. Both of these services are patient-initiated. The virtual check-in utilizes synchronous communications technology, so a phone call, for example, whereas, as the name suggests, the asynchronous service utilizes asynchronous technology. This would be something like sending a picture of a rash to your primary care doctor and seeing what they think. We also finalized separate payment for interprofessional consultations in 2019. So whereas the virtual check-in and the remote asynchronous service describes patient-to-doctor interactions, interprofessional consultations are practitioner to practitioner. So there are 5 codes that describe the work of the consultant, and these are stratified by time. And then there's 1 code to describe the work of the treating practitioner. And for 2020, we finalized separate payment for e-visits. These are essentially the same thing as the virtual check-in or the remote asynchronous service, and that it is a patient-initiated encounter that determines whether or not an in-person visit is needed, but these are conducted explicitly via a patient portal. I would also like to note that there is cost sharing associated with all of these services, and for the virtual check-in, remote asynchronous service, and interprofessional consultation, we require that beneficiary consent be obtained annually and documented in, and verbal consent documented in the patient's medical record. So finally, looking forward, what we need in order to continue to develop these policies and sort of expand these initiatives to really take into account the ways that medicine is changing to account for communication technology, what we need is continual stakeholder engagement. We do have a process by which the public can submit requests to add services to the Medicare telehealth list, and the statute requires that we review and respond to these requests annually, which we do through the physician fee schedule proposed and final rules. When it comes to payment for virtual services separate from Medicare telehealth, as we only have now like 4 sort of groups of services that we pay for, what we are looking to expand this, but what we need is information from the public, from interested stakeholders about how communication technology is being used to provide care, especially sort of oriented towards Are there services, like distinct services performed via communication technology in whole or in part that we can develop coding and payment for under the TFS? And so what we need is details about these types of services and the resource costs associated with them. And that information is very helpful to us when it comes to developing coding and eventually making separate payment under the physician fee schedule. So with that, I'm going to hand it back to Barry.
Lily, thank you very much. Bill?
Great. Questions for any of these presenters? I was actually very impressed by Jennifer, by the papers you published and your presentation. The 5% or 8% uptake, though, just seems incredibly low. You mentioned, I think, in passing that about 13% of newly diagnosed patients may receive some form of education. Can you elaborate on that? And do you think, you also highlighted how inexpensive the education is. That's a good thing and a bad thing. Is reimbursement so low that people aren't providing the service? And has any thought been given to increasing reimbursement for the services?
Thanks, Bill. I'll take the first question and probably punt the second question to my colleagues in CM, because I think that's out of kind of my wheelhouse. I'm not sure if the cost for the services has changed. I could probably check the physician fee schedule. But just to clarify, the 5 and 8% of uptake, again, was among individuals newly diagnosed with diabetes. So there's more people who technically qualify for the benefit for DSMT that we weren't capturing in our studies. It's really hard to get like a small enough denominator that you think is appropriate to look at utilization. And so that's what we were trying to do with the newly diagnosed. I brought up the statistic from the Medicare Current Beneficiary Survey, which was actually 30%. So, almost a third of Medicare beneficiaries report getting some type of diabetes-related management, not training per se, but basically some disease management services and attending a class even. And so that might be the same as DSMT, but it could be different. And I know that, my endocrinologist and many patients' endocrinologists, as kind of routine care, talk about these factors, these skills that need to be kind of handled for individuals with chronic disease. And so we know that many patients are probably receiving some training from providers, and we just couldn't fully capture that in our study. Barry, I'm not sure who could take the cost reimbursement question, but I'll leave that with you all.
Did you have any insight into the question about evaluation of the DSMT service?
Yeah. No insight, but we can certainly take the question back and do some digging if need be.
Okay, thank you.
The number was in the second article that looked at the outcomes, and the total cost of the services provided was like $30 per patient or something.
2017 article, correct?
That was the article that Jennifer had sent, yeah.
Right.
The 2017 one.
Okay.
Bill, this is Dean. I had a question for the last speaker. It was a terrific presentation. I just have to admit that it is very hard without seeing it on slides to be able to capture everything you were saying about telemedicine services. Is there a way that the content of the talk could be provided for the group in any synthesized way, or are the minutes going to reflect that so that we can digest what we heard?
So yes, well, thank you so much for your kind words. We have guidance that is available on the CMS website, but also as all of the information that I shared is publicly available in various locations, we can go ahead and just share the content of my talk. That's fine with me.
That would be great. Thank you.
Look at the PFS sort of rulemaking website, which has all of our rules for the past 10 or 15 years on it. And then there's also some MLN articles pertaining specifically to Medicare telehealth. We haven't issued any sort of sub-regulatory guidance yet on the communication technology-based services, but there's a lot of stuff out there on Medicare telehealth.
Oh, I'm sorry. So maybe can you make the distinction between those two and what that would mean for what we can take away from your talk?
Yes. So Medicare telehealth is a statutory benefit that allows payment for certain services furnished in rural areas at the in-person facility payment rate when all of the geographic site of service and practitioner restrictions are met.
Correct.
Yeah, so that's Medicare telehealth. Communication, what we're calling communication technology-based services is far more recent. And this is services that are defined explicitly to take into account the resource costs associated with payments for services utilizing virtual technology. What this means practically is that they're valued a lot lower than what would a corresponding service furnished via Medicare telehealth would be. And these are now. No, please go ahead.
But what are the differences? What are the differences in what I, as a practitioner, not in terms of the reimbursement, but the functionality? Is the communication technology functionality similar to the telehealth, or are you saying there are things like emails, or are they really like Skype phone calls where we're talking to each other on the computer?
There are numerous. So right now, telehealth has to be furnished via two-way audio-video telecommunications system. That is not as the CPDS services. That restriction is not as there isn't that sort of restriction. The only thing that we say is that for the virtual check-in, it has to be synchronous. So this could be a phone call, this could be Skype, this could be any sort of video chatting, as long as it is a synchronous interaction. The asynchronous service is an asynchronous interaction. This is, and how we defined it was either a phone or a photo or a video. Email at this point is not captured by that service. However, the e-visits that were finalized for 2020, those are via a patient portal.
Right, so, but can the new communication technologies also be synchronous? In other words, could I have the equivalent of a telemedicine visit with someone who lives in the inner city but can't transport herself to my clinic? I understand that would not. Yeah, go ahead.
Yeah, so unfortunately, as the current sort of state of the coding and payment is regarded, that would not be something that is reimbursable under this code. These are really like very brief sorts of check-ins. Like it's sort of it's not meant to substitute for an in-person visit. It's meant to sort of determine if an in-person visit is necessary. So it's not analogous to like a 992.
So that's helpful. I just want to make a point. I don't chair this subcommittee, but I do think that is a very important distinction and then also an opportunity for us to consider with respect to recommendations.
And these services, though, may be provided, the patient may be in their own home, correct? As opposed to the telehealth?
Yes, none of the telehealth restrictions apply to these services.
But it sounds like a phone call to, this is Sherry Boland, sounds like a phone call to review blood sugars and diet and would not be part of these new communication services currently, or isn't being currently discussed.
Correct.
No, that's correct, and that's why we say that we're in the very sort of infancy of sort of developing payment and coding for these types of services. So that's why I sort of request that we get more sort of interested parties should send us more information about how communication technology is being used in other sorts of services as well.
Yeah. Right, and nor would a live Skype call where we're both looking at each other talking, that would not even though that's very similar to telemedicine, that would not fulfill those billing criteria.
Well, for the virtual check-in, it would. We don't have any restrictions on communication modality, only that it is synchronous.
But that is patient-initiated, you said?
That is correct.
That is synchronous or asynchronous?
For the virtual check-in, it is synchronous.
So in terms of the dichotomy that you communicated to us before of the telemedicine versus the new communication technology dichotomy, where does virtual check-in fit in? Is that a third category?
No, that's in the second category of the communication technology-based services. There's two categories here. There's Medicare telehealth, and then there's the communication technology-based services.
So would a virtual check-in allow me on a Skype call or some other platform to be looking at my patient and she looking at me and us have a virtual visit and get any form of reimbursement?
So unfortunately at this point, no. It would only be reimbursable if your patient reached out to you and you had this virtual check-in regarding whatever issue your patient brought to your attention, and as such, the virtual check-in prevented the patient from having to come in for an in-person visit, then you would bill for the virtual check-in. It is not meant to be a substitute for a visit proper.
I understand, but but it sounds as though in that scenario, that could, if those criteria were met, that scenario could lead to a billable visit, if you will.
Potentially, yes. At that point, if an in-person visit occurred, then the virtual check-in would be considered bundled into that visit. It would not be separately reimbursable. If there is no visit that occurred, then the virtual check-in is separately billable. And I think that perhaps in the interest of time, you should feel free to reach out to me personally. You can email Gift or Marge. I think that their contact information is in the meeting materials, and then they can forward your inquiry on to me, and we can talk more about this.
Yeah, this comes up a lot. This is terrible, and this is a huge area. So I think we do want to follow up, Dean, and Bill. I mean, I think there's a lot of interest in how do we better communicate with folks at home and make it easier for patients to be addressing things without coming in.
Sure, and we'd be happy to talk to you about that more.
And are there any outbound contacts from the provider to the patient that are covered under this communication technology services?
Not at this time.
Okay.
This is Sherry. I just wanted to ask a separate question, but I don't want to derail if there's more conversation about the virtual care.
Go ahead, Sherry.
Yeah. I wanted to go back to the DSMP for a minute just to ask about the peer-led, like Stanford DSMP model and the DEEP model. And so I know the CMS was paying through the quality improvement organizations for those to occur, but we can't reimburse through Medicare for those services outside of the QIO. So I was just curious if, which seems sort of strange to me that we'll cover it one way but not another. Has there been any look at that about covering those? And if not, or if we don't know anything about that, what would be the way to pursue that? Is that something that would be sort of a rule change, or how would that happen?
So this is for peer counseling. Is that what you're saying, Sherry?
This is lay-led diabetes self-management education. So the Stanford Diabetes Self-Management Program and the Diabetes Something and Empowerment Program are two evidence-based lay-led diabetes self-management programs where there's fidelity monitoring and have had great, equal improvements in A1C compared to DSME, DSMT, which requires sort of certified diabetes educator to lead within the health system. But so that you can't bill for DSMT or E when you're using these lay-led programs that are known to be effective. And CMS through the QIOs, the quality improvement organizations, have paid for those lay-led programs and peer-led programs. So I just didn't know if there's been any discussion about that and ways to include that in how we bill for that, as opposed to as a way to enhance uptake and use of DSMP or DSME.
Well, this is a comment on the sort of dry material that I've presented before, but unfortunately, the devil is in the details, and the statute actually makes certain requirements, and the people who provide the treatment, who provide DSMP, have to be credentialed, and they have to be credentialed in a certain way. There can be other groups that provide that credentialing, but for payment to occur, it has to occur by a credentialed group or a credentialed person. and payment does not occur otherwise, and that is the only way that you can bill, and where it shows up under DSMT, in the claims data. If an endocrinologist, might be boarded, might be a diabetologist who's boarded, if they provide the training, and they are not credentialed, they cannot bill under DSMT. And so DSMT is simply statutory benefits. So you're talking about lay individual peer-to-peer counseling, and that would be outside of the scope of the current DSMT law.
So it's a statutory issue.
And is the statute, is that the congressional bill, or how are the statutes established and changed?
So if you take a look at slide 13, you can start first with public law, and that will provide you with all the information that you need. Then you can look and see how something is implemented with regulation, and you can look at the Federal Register note. And so all of this information, we had a lot of information that we had to cover today, and sometimes it's very dense. So that's why the links are here for you to peruse at your leisure.
So the statutes come from the Congress then? It's a federal law?
That's correct. That's correct. They're public law. That's what PL means, public law.
And can I ask how that translates from CMS to like the state Medicaid? And I don't know if you know that level, but I'm assuming they have to follow that same law, and so they can only make changes on things that are not like within a statute or public law. Is that correct?
The public law applies to Medicare. It does not apply to Medicaid.
Okay. So they could make a change at a state level for Medicaid, but not for Medicare.
And I think that some of these things can be done under Medicaid demonstration projects at the state level. Is that correct?
Well, I'm not a Medicaid person, so I can't.
We have a Medicaid panel on, I think, from 4 to 4:45, so maybe we'll save the questions for the experts here at CMS. I think that might be the best approach.
Can I ask?
Pardon me?
Go ahead.
And they can talk about Medicaid authorities and the Medicaid program and what benefits they offer and how the states work with that.
And the this is a separate question, but you mentioned, I know there's the 10-hour limit, and was that also part? I'm sorry, because I know you covered a ton of stuff, and I'm maybe asking something you've already said, but it was just a lot to try and remember. So for the addition, is there a way to get additional hours for people with diabetes for DSME if they have a transition or a change? I know a lot of the guidelines talk about beyond just newly diagnosed, using DSME at other times. So I didn't know if that was part of the statute with a limitation of the 10 hours, or was that lifetime, or was that just for a certain number of years?
The 10 hours applies to the first year.
Okay.
And then there is additional time in follow-up years, but there must be a reason for it. And in the presentation, I gave the reasons why you could qualify for that. And these are all laid out in either statute or in the regulation. And I think that will answer your, that'll answer your question.
Okay. Yeah, I was trying to figure out if that's something that would also be a statutory change versus sort of a regulation change. But I think we can probably figure it out from the links.
But that was fairly broad in terms of change of therapy or not achieving goals and so forth. But that was 2 hours, I believe.
It was not a lot, right? It was like 2 or 3 hours.
Great. Well, thank you very much. This has been a great session. And thank you, Barry, again, for putting all of this together. Linda, Clydette, shall we break now for 15 minutes?
They will reconvene at 3:15 for the Part B session. Thanks.
Okay, so
Yes, that's
10
correct.
minutes, 10 minutes, and folks, leave your phones on and just mute them. All right, I think we're ready to start again.
This is Linda Harris. I need to do a roll call before we begin. All right. Bill Herman.
Here.
Ann Albright. Here. Howard Tracer.
Here.
Barry Marks.
Here.
Naomi Zuccarello.
Here.
Don Shell. Bill Chong.
Here.
Aaron Lapata.
Here.
And Balak.
This is Ann, I'm here.
Barbara Linder.
Here.
David Wong.
Here.
Paul Conlon.
Here.
Ayatanda Dukan.
Here.
Carol Greenlee. David Strogatz.
Here.
Dean Schillinger. Jasmine Gonzalvo.
I'm here.
John Boltree.
Here.
Meredith Hawkins. Here. Shannon Isaac, sorry.
Isaac, here.
Sherry Bolden.
Here.
And Bill Cook.
Here.
And did I hear from Carol Greenlee yet, or Dean? Is there anyone whose name I did not call? All right, I think we can start. We have a quorum.
And it's Don Shell. I'm on.
Oh, great.
This is Barry Marks. Let's go to our next session then, and this is access to Part D drugs and formulary review. And we have with us our two presenters, Stephanie Hammonds and Robert Dombrowski.
Just Dean Schillinger's back, just FYI.
Thank you, Dean.
Hi, this is Stephanie Hammonds. I'm in the Division of Part D Policy, and I'm going to provide a Medicare Part D overview before turning it over to my colleague, Bob Dombrowski, to go over formulary review. Next slide, please. So the things that I'm going to talk briefly about are a brief history of the Part D program, how we administer Part D, what the defined standards benefit looks like for coverage year 2020, what coverage year 2020 Part D landscape looks like, definition of a Part D drug, and what is our statutory authority. So, a brief history of the Part D program. Medicare Part D was enacted by the Medicare Prescription Drug Improvement and Modernization Act of 2003. It was also known as the Medicare Modernization Act, or MMA. We published our first final rule, was published in early 2005, and we began plan enrollment in fall of 2005. And our first coverage year began January 1st, 2006. And I'll just add, if you're really interested, the MMA statute is codified in sections 1860 B1 through B43 of the Social Security Act. And our regulations are in Title 42 of the CFR, Part 423, and you can find that at ecfr.gov or by searching federalregister.gov. So how Part D is administered, private health insurers are referred to as sponsors, and they contract with CMS to provide the Part D benefit through market-based plans. Prescription drug plans can be offered as a standalone PDP, a prescription drug plan, or a Medicare Advantage prescription drug plan, an MAPD. And so, were they introduced the MAPD before? So an MAPD is basically Medicare Advantage, which combines Part A and B, and then Medicare Part D into an MAPD. So it combines all of those into a market-based, one single market-based plan. Individual sponsors can submit multiple bids for multiple plans with different benefit structures. So you may see, let's say, Humana may have 3 different Part D plans in Plan Finder when you go to look. And beneficiaries can search in Plan Finder for a plan that best meets their needs. So they can go into the Plan Finder and put in the specific drugs, doses, quantities, the pharmacies that they prefer to go to, what have you, and the Plan Finder will try to put that together and match them to a plan that could best help them. Next slide, please. So we have the coverage year 2020 defined standard benefit. We have a deductible of $435. Between the deductible and the initial coverage limit of $4,020, patients can pay 25% co-insurance, and then the plan pays 75%. And even though there was a lot of talk about closing the coverage gap for the purposes of the defined standard benefit and what the plans will see, there is still a coverage gap. The beneficiary still only pays 25% for generic drugs, 75% and 5% for the brand. And then for brands, there is a 70% manufacturer discount. The out-of-pocket threshold is $9,038.75, and after the beneficiary hits $6,350 of out-of-pocket costs, they go into catastrophic coverage. This is a co-insurance of 5%, or $3.65, and then after that, it's 80% reinsurance. So then Medicare picks up the 80% chunk of it, and the plan pays 60% of it. So I know that's a lot. That's the basic benefit, but plans are allowed to offer tiered structures that are actuarially equivalent to defined standard benefits. And plans are also allowed to offer enhanced plans, that is, plans with additional benefits in exchange for supplemental premiums. So in addition, CMS subsidizes premiums and cost sharing for individuals who meet certain criteria. And I do just want to mention again that in the coverage gap, the manufacturer pays 70% of the price of the drug, the enrollee pays 25%, and the plan only pays 5%. And I'll just reiterate there that where you see the word truth, that's the Benny's out-of-pocket cost, so the true out-of-pocket. The out-of-pocket means the beneficiary for the catastrophic phase, and it's important to note that anything the manufacturer pays in that period counts towards the beneficiary's out-of-pocket accumulation. Next slide, please. For coverage year 2020, there are more than 60 million Medicare beneficiaries, and of these 60 million, more than 46 million of them are enrolled in Part D. And of these 46 million, approximately 54% are enrolled in the standalone PDPs, and this includes some employer group plans, which are known as EGWIP, and approximately 45% are enrolled in MAPDs, which also includes some employer group MAPDs. In coverage year 2020, there are 948 standalone PDPs across 34 PDP regions nationwide, and this does exclude the 5 U.S. territories. And there are 3,148 MA plans for individual enrollment, and approximately 90% of that 3,000 change are MAPD. Next slide, please. There's a lot on this slide. This is the regulatory definition of a Part D drug, but basically I just want to focus on the things that are underlined in green. So a Part D drug means that if any of the following is used for a medically accepted indication, drug has to be dispensed upon a prescription and be a biological product, insulin, supplies associated with the injection of insulin, a Part D vaccine, so vaccines licensed under Section 351 of the Public Health Service Act, supplies that are directly associated with delivering insulin into the body, other than the injection supplies. And then you can also have combination products approved and regulated by the FDA as a drug, vaccine, or biological product. It's important to note that a Part D drug does not include drugs for which payment is available under Medicare Part A or B. So Medicare Part D is the last payer. It also does not include drugs excluded or otherwise restricted under Medicaid. And it also does not include medical food. So medically accepted indication includes indications in the FDA label and some off-label indications if they're supported by the official compendia. I just want to draw your attention as well that Part D vaccines include flu, TB or Tdap, shingles or zoster, and pneumococcal and chickenpox if you did not get this as a child. And there's a pretty long list of excluded or restricted drugs that are available to sterilize. And then it's important to understand the limits and the reach of our authority. So there's the non-interference clause, section 1860 11I 1 through 2 of the Social Security Act. So we cannot interfere with the negotiations between drug manufacturers and pharmacies and PDP sponsors. And we also cannot require a particular formulary or price structure for reimbursement. And then we're also limited by the non-discrimination requirement, which is section 1860 11E2 DI of the Social Security Act, which is that we cannot approve plans that are likely to substantially discourage enrollment by certain beneficiaries under the plan. And this is the authority that we rely on for our extensive requirements during the annual formulary review and approval process. And with that, I will turn it over to my colleague, Dr. Brown.
Thank you so much, Stephanie. So I'd like to, just go over some of the things for our IT formulary review. And, it's a nice segue that Stephanie provided. I think a misconception is that, we design or require a certain formula, and actually what we do is we review formularies that are submitted to us by Part D sponsors to make sure that they're compliant with their requirements for giving a robust benefit for beneficiaries. So I'm going to talk as an overview and just about the formulary reference file, the Part D formulary submission process, how folks deliver the formulary to us for review, and go over some of our review checks, and then hopefully answer some questions you may have at the end of the presentation. So Part D sponsors much of the formulary has been developed and reviewed by a pharmacy and therapeutic committee. And that pharmacy and therapeutic committee actually is responsible for decisions for which drugs are covered by the formulary. And these decisions should be made based on scientific evidence and practice, peer-reviewed literature, pharmacoeconomic studies, and outcomes research. The P&T committee also must review utilization management restrictions that can be applied to drugs, prior authorization, step therapy, and quantity. So, as background, CMS reviews hundreds of formularies. Each of these formularies contains thousands of drugs for review. And the initial formularies are submitted by the first week in June. That's the deadline. They have about 3 weeks to start in the middle of May, and they submit by the first week in June, at the beginning of the subsequent contract. Right now in 2020, we'll be working on stuff for 2021, getting in preparation for the annual review cycle that will happen. Due to the volume of submissions and the review time frame, we need a standardized submission format. It's critical for us to be able to review formularies based on. So you can imagine we've kind of evolved over time. Rather than a plan submitting every single NDC that they're covering, what we do is we have kind of a fixed list. We call it our formulary reference file. And this is what formulary plan to develop this formula. It serves as a listing of drugs, and what they can do is pick from this posted formulary reference file that we supplied it. And it includes proxy and receipt, brand name, generic name, brand stop administration, dosage. We'll go into that in our next slide. But RX norm is a formalized naming convention system that is from the National Library of Medicine. After this, I think in 2010, to help with us and help sponsors with submitting formularies. So this is the formulary reference file format, and I apologize because I know it's really hard to see, but each of the bulleted items is something that appears on the reference file. So in our experience, a unique numeric identifier in the far left corner of the table. And the next item in the table is TTY, and that just stands for whether it's a brand or a generic STD. Generic STD is brand. And then there's the RX norm description. And if you look at this example with the total 100 milligrams, the tartrate, it shows, the RX norm description shows that which is a generic, and it has a brand name for that one branded product there, the low pressure 100 milligrams. Again, there's another section that just isolates brand names, low pressure there. The FTDC is almost like what we consider the generic name. It's called significant clinical drug. And the dose form is listed, and the related NDC is the NDC that often is planned flexing comments and shows up in plan finds for pricing purposes. And the quantity limit unit is far away in corners of the brand feature ML. So that's basically with the reference file format. And plan to select drugs based on this kind of a thing. And just to clarify, that one RX treat, the so-called tartrate, is representative in the plan wants there may be 100 metoprolol manufacturers out there. They may choose to cover 75 of the 100 metoprolol manufacturers that do metoprolol generic. So it's representative of a multitude of. So again, to iterate that point as a representative of multiple entities, inclusion of an RX treaty on the reference file kind of reflects our understanding that one or more drug products can be represented by the CUI can satisfy criteria or inclusion into the formulary reference file with drug products potentially published at least one NDC has to be listed in the NSC file from the FDA, comprehensive FDA element file. Other requirements are that it's available on U.S. market. Oftentimes the drug is approved, but there may not be market availability. It should be flagged as active in first database medicine. Should be included in our form and should have a label agreement that covers that discount code. So, how formularies are reviewed? Submitted to us and reviewed in Health Plan Management System, HPMS. Plans upload a capitated text file. The text file has those RXQs. Those RXQs that they want to cover with their utilization entry requirements of TA, step therapy, care placement, what kind of category of class of patients they're using. And we have checks in place. Like right now, we're ramping up for the 2021 formulary submission. So we put in a lot of validation checks, and I'll kind of go over some of these checks. But after these submitted to us, they bounce up against our checks. And if there are deficiencies that are noted, sponsors can provide a clinical justification or just revise their submissions for missing a drug that we think that they should have on the formulary. The final stage of the review involves addressing any unresolved issues in formulary negotiations or conditional approval. So, the last phase is somebody hasn't resolved all the issues that are outlined. We have three stages that we go through a negotiation process with them. We give them a call and they can tell us, hey, we feel that our justification is appropriate. We either there's something that wasn't clarified, or they just forgot to often they forgot to forget what we request. So this is a nice representation organized fun. So stage one is this process takes place in summer months in June and July. And stage one is really looking for deficiencies of drugs that are part of the drug list that are part of the sponsor submits to us. So we're looking for a robust check of getting the medical literature for treatment guidelines, so we widely accepted treatment guidelines. And we look at the drugs and how they're categorized and recommended in those guidelines, and we put them in our review check. So if there's a deficiency with these drugs, the formula comes in, and the page can show them it shows ways that they outline. Treatment guideline check is one of our more robust checks. We also look at categories and classes, and deficiencies in categories and classes that are submitted to us. We make sure that those drugs. We also look from PD data that are the most commonly used drugs in Medicare, and we make sure they're representative drugs in the category class are part of that somewhere. The deficiencies there will let them know that. So this is all kind of building any drug with deficiency. We also look at check the class reviews of drugs in the class. Omitted from things. Normally our responses know what they have to do for that. So it's not really a lot of outliers for that. And two, kind of looking at some of the limits that folks put on drugs. You look at if they put a lot of PA on PA for drugs that many people didn't use the PA for requiring limits, and some people didn't put requiring limits on. We'll ask them, hey, why did you do this? And give a justification to us. So it's kind of an iterative. All of these, everything here is iterative. If they want to push back and say, missing a drug from the treatment guidelines, they will say, this is why we didn't put this on our formulary. We feel this other drug covers it. And we review that and see if it makes clinical appropriate sense or not. And the same is true with this. So we look at the QL amount to make sure that it's covering a sufficient amount for beneficiaries so that they're not, halfway through a dose, can't get through a dose escalation in the FDA label and come back. Plans can not submit things that are safe yet 2 or 3 times with one FDA dose. So we understand that that's the case. But the QL amount can be the things that may not be clear with the safety yet it is, and we look at what the protein and what that amount is. We have to look at tiers and ensure that we're not being discriminatory and have everything on not preferred tier or high cost share tier. We have special tier reviews of stress threshold status. We want to make sure that if they put something in special tier, indeed qualifies for special tier. And if you look at restricted access, make sure that it's not putting secondary CSPA on everything in a certain class, unless it's something that, through best practices with that for folks in the private sector, private organization sector, requirements, and restrictions. And then, as we go through all those stages, the stage 3 is the remaining issues. They didn't do it, they want an opportunity to fix it, or they can negotiation. So that's pretty much the crux of formulary review. And that's just looking at what the drug list that is submitted to us. So here's an example of the formulary review tools that we talked about. So this would be, I think, for hypertension, this is looking at an ACE inhibitor. Now, ACE inhibitors can be a part of congestive heart failure guidelines, even diabetes guidelines. They can be a part of atrial fibrillation guidelines that are incorporated into lots of guidelines. So just because it's in one guideline doesn't mean that we don't include it in other guidelines that they're called out. So the review tool, so we'll put this kind of in our system, and we want to make sure that the presence of these drugs have an alkyl or cyclical, so these drugs that can satisfy this review check. Okay, so this is what might come back with things an outline. So for this treatment guideline review, for lipid disorders, they get this report in treatment guideline review with the outlier, lipid disorders missing a ancient conductase inhibitor for atrial fibrillation, missing oral anticoagulant, hypertension, missing an ACE inhibitor, and for migraine, receptors. So that kind of gives the deficiencies of the plan. They can respond by either giving us a justification or adding the drug, and that outlier will go away. Once all those deficiencies for a plan this is that we actually look at step therapy and prioritization criteria that are written. I think the labor intensive review. We work with a contractor. We make sure that the criteria are consistent with FDA labeling, that with Kenya and widely accepted treatment guidelines, we use criteria for that. Again, it's an iterative process about phase 3 phases. Usually we look at it, release them in September, and get through the 3 phases by November. And if something wasn't done again at the end, by the 3rd phase, we call it hospital. This is what your outlier is to justify why you put this restriction. So one of the last things we want to talk about is Medicare plan finders, beneficiaries, when they can go into Medicare.gov, see if the drug is covered by the plan, maybe what the cost share is, a tool that folks can play with. And it also tells the visualization requirements for the entering time of prioritization that there. When you go into Medicare.gov, you can list in here, type in the drug name that you want. Both entered with low cresser, and it's telling me that a generic is available. If I wanted a generic, if I wanted to go generic, add generic, cost share. Generally, the cost share is pretty low for this, thankfully, as well it should be. And it'll list what the options are. So just in summary, the FRS is especially unique identifiers that we use for RTD plans, like formularies for us to review. You can imagine if they were submitting 70 NDCs for one drug, how huge the file would be. So this really streamlines the process both for the plan sponsors and for us at CMS. So we're really taking down the amount of efficient work for them. And even then, it's still huge. There's a process. They submit their formulary to us, the UN tools and share information in early June. And it's a very comprehensive process that we go through when we review these. And it's an iterative process. We talk to plans about what they submitted when they're on decision. Most times they agree, they see what they're on. And at times there's a good clinical discussion between the plans and Thank you very much. Thank you. Bill?
Yeah, thank you, Bob and Stephanie. And Stephanie, the Part D plans, did you say that you can only get them through Medicare Advantage, or how does that work in the fee-for-service arena versus Advantage plans, and what are the options? Does a single Advantage plan offer multiple formularies?
So a patient who has a Medicare beneficiary who has Medicare Part A and B can go and sign up for a standalone Part D plan. And when they go into the plan finder, they could have various Part D plans to choose from. Similarly, if they are going to choose a Medicare Advantage plan, they would have multiple Medicare Advantage plans that also provide Part D coverage. So that is to say that a Medicare Advantage plan with Part D, and then MAPD rolls up into one plan, Part A, B, and C. But yes, when they go into Plan Finder, if they're searching for MAPDs, they would have multiple options to choose from.
And 20 or 30% of Medicare recipients do not opt for Part D. Do you have any insight as to why that is?
Yeah, referring with Craig Miner here, that part of that may be because they may just have other coverage.
Is cost an issue there, just to follow up on that? Like, do people not get Part D due to cost?
Part D does provide a low-income subsidy, so for beneficiaries to meet certain criteria, Part D does subsidize the Part D program for those bennies.
Gary, this is Bill Cook. Sometimes the minority of patients that are in their upper 60s that aren't on any medications or just on one that's real inexpensive feel like that between the deductible and what they have to pay, it's better. It's no sense signing up for it.
Yeah.
Not a huge amount though.
Okay.
This is Bill Herman again. I had a question for Bob. Is the formulary reference file then basically a pick list for the sponsors to, they have to take certain drugs from various categories and they just put together the program? And then in the formulary review stages, the stepped therapy and the tier and the prior auth and all that, it seems to me that that's usually based on cost. Are you sensitive to that if there's a new class of drugs that's very expensive, but the guidelines support its use? Do you ask that they be put at a lower tier or a lower copay?
Okay, so to the first part of your question, it is essentially, the reference file is essentially kind of a pick list, so they can develop their formulary based on selecting some of those drugs. It's not just limited, claims aren't just limited to what's on the formulary reference file. There may be drugs that they want to cover that we would think would be predominantly Part B, but could have maybe a Part D use, and they could cover them as well, and they would post that on their marketing materials. I guess the second part of your question was about PA and step therapy probably being secondary to cost. It's not always cost. It often is cost. There could be clinical requirements that we think are restrictions that may, protect beneficiaries and make sure, like ESAs are a good example, for the risk of tweaking that, if they see a certain hemoglobin level, there could be, increased mortality. They could want certain monitoring parameters that are routinely done and clinically evaluated. You would think that a lot of times, P&T committees are the folks that are developing these based on reading these guidelines as well. They read the medical literature, so they make their own determinations from a pharmacoeconomic standpoint and from a standpoint of efficacy, what they think is best. And we try to review according to best practices and what we see.
But the guidelines would be professional societies like the American Diabetes Association. Is that the guidelines that they're presumably reviewing?
Yeah, it would have to be something that's a widely accepted treatment guideline that we would use, that folks would have access to. That, wouldn't be, something that's more esoteric. It would be something that folks would have access to.
Good. This is Bill Cook again. Just another pain point from the provider standpoint. We go through this horror show every January when insurance companies will switch from one ACE inhibitor to another, and we get this barrage of calls. We've got to switch everything over, and sometimes if it's a drug that needed prior authorization previously, it has to be done all over again for a condition that could be lifelong. Is there any sort of thing going on in CMS to try to look at a way to sort of streamline that so that it's not occupying so much time in the providers in their offices?
Yeah, this is Craig Minor. Yes, we're constantly looking at that. We understand, it's this balance between the plans and the competitive marketplace and trying to ensure they can provide, benefits that, they can achieve decent premiums and that with this idea of continuity of care and the changes. As you know, in Medicare, we have a transition policy so that the patient can get at least a fill during the first 90 days if there was a change or they're new to that plan and the drug they're on is not on the formulary or otherwise restricted by PA, to give them a chance to go through the PA process. I do think going forward, electronic prescribing and having electronic prescribing up front at the point of care and not when the person's going to the pharmacy could help. But we are trying to look at other things too, how do we decrease the burden, but also kind of make sure that, we're being good stewards and people that need the medicine are getting it, but not people that shouldn't be getting it.
And has CMS thought of doing anything to direct physicians or patients to generic alternatives within classes? Sometimes people will be on brand name drugs when there are good generic alternatives, a different drug but the same effect, to just keep down their total out-of-pocket burden.
Yeah, I mean, the generic substitution rate in Part D is up north of 90%, I believe. The generic dispensing rate, I think is a little bit lower. So where the opportunities are, so when it's actually a generic for the brand, we are seeing that, people pretty much get the generic. Where there's still opportunities, perhaps, is within a class when maybe there's some generics, but there's some brands, so not the actual substitutable product, and whether, people could be educated enough that, or more, that they, can move to the generic alternative or whatever. But plans do a pretty good job of that, I would say.
So you see that happening at the plan level rather than the CMS level, though?
Yes.
Yeah, and I discussed, essentially, what happens, an initial formulary submission. Once the plan year starts, there are monthly formulary submissions where plans can substitute generic and like immediate substitution for those plans that selected that they can immediately substitute generic for branded products when they come out. A lot of times limitations that the generic may be approved, but it hasn't been to market yet. But as soon as it does, I think, based on how pharmacists substitute as well, and encourage generics too. That's why we have to look at.
And I know the Part D legislation says that, I guess, you can't negotiate on price. Do you see any way around that, or any movement in that issue?
I mean, not specifically under the current authority.
Is that something you think would be useful for Medicare Part D? And if so, who would address it, or how would it be addressed?
Yeah, I don't think I'm really in a position at my level to speak to that. Obviously, there's a lot going on in that arena, the drug pricing arena, but how exactly that would work, should CMS have the authority to negotiate, I really can't address.
Yes, this is Meredith. I wanted to follow up on that point because I think it is an important one. When we think about, for example, Canada, and we think about the fact that there is enormous negotiating capability by the government as a major purchaser of drugs, and when we think about the vast discrepancy in the amount that's getting paid for certain drugs between Canada and the U.S., a lot of it having to do with that. And I would just be intrigued. I think it's an excellent question, and I would just be intrigued to know if we would even have a ballpark idea of how much could be saved by the federal government if negotiating were able to enter the picture here.
But in my position, I really have no idea. But I can't give you a good answer.
Any final questions?
Bill, this is Barry, just a clarification. Stephanie?
Hi, this is Stephanie. As I was looking at the list of vaccines on my paper, I just wanted to clarify and correct something that I said. I misspoke. Flu vaccine and pneumococcal vaccine are covered under Medicare B as in boy, not B as in dog. But the other ones are covered under B as in dog. So that's all I had.
Great, thank you. Good. Well, Stephanie, Bob, thank you very much. That was very, very helpful. Barry, do you want to carry on?
Thank you, Bill. So we're moving on now to our next session, which is on the Section 1115 demonstrations, non-emergency medical transportation, and the Medicaid core set. And we're joined by a group from the Center for Medicaid and CHIP Services, Judith Cash, Alyssa DeBoy, Kristen Jensen, Melissa Harris, and Karen Matsuoka.
We're missing Karen, but I'm sure she'll join us momentarily.
Okay.
Because she began a little bit late, and she will be there.
All right, very good, thank you.
Okay, so we got this?
Yes, please.
Great. So good afternoon, everyone, and thank you for inviting us today. We bring greetings from all of the Medicaid teams in the Center for Medicaid Shift Services. I think we're going to tag team this a bit. I'm Judith Cash. I'm the director of the State Demonstrations Group, which has the responsibility and oversight of all Medicaid Section 1115 demonstrations. After me, you'll hear from my colleagues in the Disabled and Elderly Health Programs Group to address the NEMT questions that you all had. And then the third leg of our stool will be Karen Matsuwaka from our Quality Division to talk about the quality strategy and meaningful measures. So I think we're all going to kind of give you some information, hopefully address some of the questions that you had, and then we'll open up for whatever additional questions you all might have that we didn't answer this afternoon. So, and I'll also note I'm joined by Danielle Daly, who's the director of my division of state monitoring and evaluation. So, as mentioned, the State Demonstrations Group has oversight over all of 15 demonstrations and waivers, and that includes both working with states in the process of understanding what a state wants to do in the demonstrations world, and then after we've approved a demonstration, to do all of the really important monitoring and evaluation of those demos to make sure we understand what's happening. So you all had specifically asked a question about the impact of particular Medicaid waivers on access to care and health outcomes, and what data do we have? And so I would like to address that question in particular, and then give you some general information about Medicaid demonstrations so that you can understand the puts and takes and what we can and hopefully will know about them. But the short answer to your question primarily is not yet. In that a number of the demonstrations that I think you all are particularly interested in are still fairly new in many cases, and in some cases have not yet been implemented. And so we are still collecting data to really know about the the impacts and outcomes. But we'll talk a little bit about that as I get into the presentation. So just wanted to make sure that we start with some general grounding about what Section 1115 demonstrations are all about. And Section 1115 is really the part of the statute that allows us in Medicaid to work with states to support their interests in implementing experimental, innovative, pilot kinds of programs that they can't otherwise do under the regular rules, if you will, of Section 19, Title 19 of the statute, which is the Medicaid section of the statute. But what Section 1115 of the statute does, it allows the Secretary to approve a state where it wants to test something that it can't do under regular authority, and where that test is expected to promote the objectives of Medicaid. And really, Section 1115 really gives us two different ways to do that. So one of the ways that we do it, and one of the things that people talk most about, is our waiver authority. If you go to the next slide. Section 1115A1 of the statute allows us, on behalf of the Secretary, to waive particular provisions in Title 19, such that the state wouldn't have to apply that. So, for example, if a state wants to provide a service not to everybody in the Medicaid program, which is to pilot that with a small population of people, we can allow the state to waive the requirement that says a state has to treat everybody who would otherwise be in the same eligibility group in the same way. We can waive that so a state can do something a little bit different to test that with a particular population. There are a number of other sections of the statute that we can waive, but it's important to know we can't waive them all. We really are limited to only waiving parts of 1902 in Title 19, not the entire title, not the whole title. The other provision in Section 1115 is A2, and that's the one that allows us to allow states to actually spend money and get Medicaid matched for that money where they wouldn't normally get those expenditures matched. So things that a state might want to do in its Medicaid program, so to cover a particular population of people that are not otherwise eligible, or to provide a particular service that's not otherwise a Medicaid service. They want to provide that service, cover those people, pay for that,
and have us at the federal level match those state expenditures like we do in the Medicaid program. And so both of those authorities together make up what 1115 gives us the opportunity to do. So we often hear the term waiver used as kind of a shorthand for all Medicaid demonstrations, but the fact is waivers are only part of it. The other important part is the ability to spend money and to get matched for that money. But then what that allows us to do is let states really be those laboratories for innovation where they can manage, administer their programs in a way that best meets the needs of their population. So whether that is improving access to care for particular populations, giving them unique ways to promote efficiencies, so, supporting coordinated strategies to address things like social determinants of health, the other things that we know contribute to a beneficiary's overall health, strengthen beneficiary engagement in their health care, so by requiring beneficiaries to pay premiums, for example, to engage in certain incentivized behaviors. We also have a number of states that are interested in lining up Medicaid with the commercial market, and so making necessary changes to their service delivery model or their benefits package to line up with their commercial health insurance, and to look at ways to move towards value-based care. As you may be aware, this administration has a high priority in really moving from a system that promotes volume to a system that really promotes value. And we, of course, expect the Medicaid program to do that as well. And so a number of states are looking at a variety of service delivery changes so that they can move towards a more value-based driven and value-driven system. In a number of states, we have states using 1115 authority to expand coverage, to use it to usher in managed care, to provide a range of home and community-based services in ways different from what the statute allows, to provide family planning coverage or coverage for HIV and AIDS. We have a number of states that have taken up a recent opportunity that we have provided to enhance their systems for services to people with severe mental illness and or substance use disorder. And also, as I mentioned, promoting social determinants of health. So just to give you a sense of the breadth of 1115 demonstrations, most states, the vast majority of states, have at least some part of their Medicaid program in an 1115 demonstration. And it really varies. We have a few states that actually run almost their entire Medicaid program in an 1115 demonstration. We have other states in which, of course, most of their Medicaid program is through their state plan, their contract with CMS that shows us how they're actually following all of the rules, and just have a small little waiver or a small expenditure authority to let them test one unique aspect. But there are 67 currently demonstrations across 46 states, and it represents almost $1 in 3 dollars in the Medicaid program in terms of our federal outlay. And you'll see here that the types of demonstrations that we have, the community engagement demonstrations, which were a priority of this administration, the SUD and SMI that I just mentioned, a wonderful and wide variety of enhancements to home and community-based services, lots of states that are integrating behavioral health care and physical health care in some unique ways, and a number of other unique approaches, including the most recent one that many of you may have read about over the last couple of weeks, which is the Healthy Adult Opportunity, which is a new opportunity for states, particularly for populations that they cover at their option in the state plan. So I just want to close with a few minutes on how we monitor and evaluate the demonstrations. So we take our responsibility of allowing states to test and demonstrate things very seriously. And we really want to understand what states are testing. These are, in fact, experiments, and they require careful implementation as well as rigorous monitoring and evaluation. And so because there's a range of flexibility provided, it really creates for us a need for a strategic approach to both monitoring and evaluation. So our vision is that with this robust monitoring and some standardized approach to evaluation, we really do understand more and better about how demonstrations are being implemented, so what's actually happening on the ground, so that states can use that information to make course corrections as they go, that learning can be shared both with CMS and across states, and then ultimately we really know what are the outcomes for the individuals who are affected by the demonstrations, what are the impacts that they are having as compared to not having the demonstration, and all of those that we can measure and report. So we see monitoring and evaluation as two very different, although very related activities. Monitoring is what's happening now. How can we know from states? Are they doing what they're supposed to be doing? Are they in compliance with the terms and conditions of the demonstration contract? And then really what's happening as they are implementing so that they can quickly be informed, we can quickly be informed, and as I mentioned, as necessary, states can make course corrections. So we really want to know that they are complying with the SQCs and learning as they go. Evaluation, on the other hand, really tells us more in the long term. What's happening as a result of this being implemented, what's happening to beneficiaries, what's happening to the federal and state dollar, and how can we really understand that X is happening because of Y, and not just that X and Y are happening at the same time. So we require all states, as a condition of approval for a demonstration, to have a robust independent evaluation. They submit to us quarterly monitoring reports, and then an interim, and finally a summative evaluation at the end of the demonstration. Those are all made public and posted on Medicaid.gov so that everybody can be aware of what's happening with demonstrations. And we are informed by that information. So again, a little bit about the kinds of things that states report to us. And I will say that CMS has, just over the last probably 4 years or so, really spent a great deal of energy and our capital in ensuring this really robust approach to evaluation and in providing tools to states so that they can be successful. So we have provided a great deal of evaluation guidance. We've published a variety of white papers, and we've developed a number of tools, protocols for states to do monitoring, protocols for their reporting, and recommendations for the design of their evaluation, which of course is subject to CMS approval. So again, wanted you to take a minute here on the community engagement demonstrations because I know that those are ones that you are particularly interested in. So, as always, subject to rigorous independent evaluations, the evaluation designs are subject to our approval, and we expect those designs to really show us methodology, data collection, and really a clear set of hypotheses and research questions subject to a great deal of scientific rigor and evaluation expertise. And that has been informed not just by our own internal evaluation expertise, but by states and by the overall research community, which has been very supportive of the work that we are doing. And so you'll see that, we try to really maintain consistency with strong evaluation concepts and hold states to that standard and a high level of accountability. So in particular, the engagement demonstrations, which I know you all asked about, at this time, we only have one state that is actually implementing a community engagement demonstration with student engagement as a condition of eligibility, and that's Michigan, which just got started. Indiana has also started its demonstration, but is not conditioning eligibility on meeting the requirements. They've kind of put that on hold. As I'm sure you are aware, we have a number that have been challenged in the court. And just last week, we got a decision from the Court of Appeals that upheld the lower court decision that determined that the approval that we did in Arkansas was not legal, and so that program has remained vacated. So a number of others that are pending that we are continuing to work on, but this remains an interest of the administration. And for those that do implement, we will be receiving monitoring reports from them, and ultimately, if they prevail, we will have strong evaluation data. So I think I'm stopping there. I'm going to turn it over to my colleagues, and then we'll open to questions at the end.
Right. Thank you, Judith. This is Alyssa DeBoy, and I'm the director of the Disabled and Elderly Health Programs Group. In my group, we have responsibility for coverage policy under traditional state plans, and we often work with Judith on some of the 1115 to support some of the policy decisions there. But you had asked questions about non-emergency medical transportation and about why CMS is allowing states to change NEMT from mandatory benefits to an optional one. And so I wanted to provide some information to clarify what CMS is doing. So current regulations, as you know, require states to provide an assurance of transportation to all Medicaid beneficiaries. In the President's budget for 2019 and 2020,
2020, the administration committed to providing states additional flexibility through a regulatory proposal to change the provision of this benefit from mandatory to optional. And so in keeping with the direction in the president's budget, CMS is looking at this policy in order to take a deeper understanding of the need for state flexibility and the impact of changing the assurance from mandatory to optional. CMS will be issuing an RFI, and which we'll be asking a series of questions and request data to help us inform this proposal. And so at this time, that RFI has not yet been released, and no rules have yet been proposed. So that's really all about the update for that particular topic. So I can turn it over to Karen Masloka for the course set question.
So the question that was asked, as I understand it, is why, given the agency's heavy emphasis on insurance of health, do you not see the insurance health measures on Medicaid to child and adult care? So to just briefly address that, I thought I would run through a couple of things. One is to say a little bit about what the process are. Two, talk a little bit about what the process is as mandated by statute for any given measure to land on the process. Three, to challenge the notion that actually we don't have any social determinants of health measures on the process. And then four, to the extent that I would argue we have them, to talk a little bit about how states are already. So,
Karen, I'm having a little trouble hearing you. Are you close to the phone?
Stand on the table, Karen.
There's a microphone right here. Maybe if you can go where Judith is, potentially, or just Judith, you can slide down a little bit. I know, it's right over her head. Maybe they can hear you better from there.
So I do want to say, and I apologize, but we have a leadership meeting at 1:30.
Oh, sure.
So I know I don't want to short circuit any of Karen's presentation, but if there are any questions on NEMT, I wonder if you can take those early. And I do apologize. Otherwise, I can leave, and I can leave my deputy Melissa here to answer questions, but I have to go to a leadership session.
So, Bill, are there any questions right now on NEMT?
And I apologize.
Sorry, is that for Judith or?
Alyssa.
It's Alyssa DuBois.
For Alyssa. Alyssa's going to have to leave us in a few minutes.
NEMT issues.
Yeah. So is there any evaluation plan for this change from the benefit from mandatory to optional in terms of utilization and health outcomes?
So I can't speak to that because we don't have, a proposal, out for public comment, so I will say that we are issuing an RFI to seek, information that will be helpful to CMS in crafting a proposal. And that is, I guess we encourage all of the public to look at that RFI and the questions that we posed in there. And likely we will be seeking data. And I will say that in terms of any regulatory proposal to remove the mandatory assurance to optional, that will go through a notice of proposed rulemaking cycle, which again will be a proposed rule that will seek comment from the public before it is made final.
Great, thank you. Other questions for Alyssa? Okay, thank you very much. So Karen, did you want to go ahead then?
Sorry. Okay. So I'll just start over so that folks can hear. So the question, as I understand it, can folks hear me better?
Is Karen coming through better now?
Yes.
Outside. So I understand the question to be, given CMS, the agency's interest in social determinants of health, why is it that there are no social determinants of health measures on the Medicaid and CHIP child and adult core set? So to answer that, I thought I would cover 4 different points. One is to provide a very brief overview of what the core sets are, what statute says they have to be. 2, what the process is for any measure to land on those core sets, whether they're social determinants of health measures or any measure. 3, to challenge the notion a little bit that there are no social determinants of health measures currently on those core sets. And 4, talk about how states are already using those measures in innovative ways to drive down or improve on the social determinants of health to then improve the performance on those core set measures. So really briefly, what the core sets are. The core sets, for those of you who are more familiar with quality measurement as it happens in sort of the Medicare space, that's certainly where my academic training has been. You may be very surprised to learn that in the Medicaid and CHIP context, there was no national quality measurement program until 2009, when CHIPper came around and said, we really ought to know how we're doing for the kids who we cover in Medicaid and CHIP. When the ACA came around in 2010 and Medicaid was expanded to include a lot more adults, Congress thought, well, we may want to have a national quality measurement program to see how we're doing for the adults that we cover in the Medicaid program. So it really hasn't been all that long that we've had any kind of quality measurement program or infrastructure to do any of this kind of work within the Medicaid and CHIP context. And what Congress said was very specific. They said that these measures should be the measures which can be reported to us voluntarily by states that taken together can show us at a national level how healthy our beneficiaries are. So for all the things that we're doing with regard to coverage, benefits, payments, how much of this is having any kind of impact at all on what ultimately matters the most, which is the health of our beneficiaries. So Congress was very specific about what the role of these measures needed to be. I'll just note again that Congress noted that these would have to be voluntary. That's changing a little bit in 2024, but up until now and until 2024, these measures are voluntary. And Congress also said that there has to be an annual review process by which CMS makes decisions about what's on that core set. So we do have an annual process. Through that process, our expert work group members do take into account many things like the relevance of measures for the Medicaid and CHIP program. We can't measure everything, so there is ultimately need to prioritize what are the most important things. And key to this, since states are the ones that are reporting these measures to us, is the extent to which states find it important enough and feasible enough to report these measures to CMS. Because if less than 25 states are able to report any of these measures to us, we are not able to provide the national picture that Congress has said these core set measures need to provide. So to the extent that the folks on this call believe that the right kinds of social determinants of health measures are not currently on the core set, has to do with the extent to which measures that our expert work group panel of members feel are pertinent, relevant, and feasible for states to report within the Medicaid and CHIP context. That can always change. This is an annual process. And so I think as more measures become available, I think many more measures will be considered. But thus far, to the extent that folks on the call don't think the right ones are there, that would be the reason why. But I will, as I mentioned, challenge the notion somewhat that we don't have social determinants of health measures on our core set. I would argue that most of the measures, if not all the measures on both core sets, are what I would call social determinants of health sensitive. Folks on this call might be familiar with the term ambulatory care sensitive measures. These are measures, let's say, of avoidable hospitalization. And certainly you can think of those measures as resource use or cost kinds of measures, but they can also be thought of as the extent to which we are doing what we need to be doing through the healthcare system to improve the health of our beneficiaries. And to the extent that we're seeing a lot of these avoidable hospitalizations, for example, that would suggest that we're not doing enough. And so just to give you a quick example, we have measures on our core set like timeliness of prenatal visits, or on our child core set we have the extent to which children are receiving at least one cent of dental service. Anytime we see that these fairly low bars are not being met at the state level, can suggest that there are things like transportation barriers, or perhaps not enough of an adequacy of a supply of the right kinds of providers in a given area. So maybe they're not measuring social determinants of health explicitly, but they are very sensitive to the effects of social determinants of health. And in other areas, let's say asthma, we have measures that can be used in conjunction to really get to this issue of social determinants of health. So for example, we have a measure on both the adult core set and the child core set of asthma medication ratio. So this is a really good measure to see the extent to which our Medicaid and CHIP beneficiaries who have asthma are really kind of taking their medication regimen seriously and adhering to what the clinical guidelines say they ought to be doing. We also have a measure that we encourage our states to be thinking of in partnership with that measure of avoidable hospitalizations and ER use for asthma. And so in states where you see very high performance, let's say on a medication ratio measure, but you're nevertheless seeing very poor performance on the avoidable hospitalization per active measure, is a very big clue that despite the fact what you're doing in the healthcare system seems to be working, clearly from a healthcare medical point of view, the clinical advice is getting through to your patients. Nevertheless, something else is happening because these patients are ending up in the hospital. So these are some of the creative ways that I would argue that social determinants of health measures are actually on the course set, and states are actively using them currently to really address social determinants of health. And to the extent that they're able to do that effectively, they do see improvement on the performance on the course set measures. So just to give you a really quick specific example, we have states like Michigan. So Michigan leveraged their managed care quality authorities and used them in conjunction with the course set measures. What they did was to have their health plans implement enhanced care coordination and a transportation benefit intervention for their maternal infant health population. As a result of that, they were able to, and as part of that, they assessed women's physical recovery from pregnancy and childbirth, whether they were providing breastfeeding support, managed treatments for emerging chronic health conditions, evaluated for psychological and mental health status, and discussed non-inclining options, and then set the stage for well-woman care between pregnancies. All of these things were then tracked through the use of the course set measure around prenatal care and postpartum care. And even though they weren't necessarily tracking the social determinant of health, they were incorporating what they knew to be a social determinant of health for this population, which was lack of transportation. And they included that as part of what they had the managed care plan to do. And as a result of that, they saw incredible performance results on those various course set measures. So I'll stop there and see if there are any questions.
Great. Thank you. Questions? Going back to Judith's presentation, the evaluation are the funds for the external evaluation rolled into the demonstration project, or how are they funded?
Yeah, so states need to include the costs related to the evaluation in the overall budget for the demonstration, and are allowed to claim federal match at the administrative level for those expenditures. We know that is an issue in a number of states. The range of resources available from state to state, both internally and externally for evaluation, I think, remains large. And so the amount of money that a state has to be able to spend on evaluation varies dramatically from state to state. But there is federal match available for those expenditures.
Great, thank you. Other questions? And Karen, do you have, I should probably know, but is there a reference for the core data set for the Medicaid core set? And does it have diabetes related measures in it?
Yes, we would be happy to, and I'm looking to see if maybe Gene is the right way to get the information out. But we do, all the core set measures are available through Medicaid.gov.
Okay, great.
And diabetes is on there.
Good. Other questions? Great. Well, thank you all very much. Barry, shall we move on?
Yes, indeed. And again, thank you very much.
Our pleasure. Thanks for having us.
The next and final session on the agenda for us is model testing and the Medicare Diabetes Prevention Program. We have Nita Brown Ashford, Deputy Director of Prevention Population Health Group, and Elizabeth Matthews, Director of the Division of Healthcare Delivery. Nina?
Yes, great. Thank you. Can you guys hear me okay?
Yes.
Great.
Great. So I'm going to provide a high-level overview about CMMI and what we do and our model test, and then Liz is going to jump in a little more detail into the NCCC program, and then we will answer the specific questions that you guys sent in advance. So feel free to go to the next slide. So the Innovation Center, as you guys probably know, was created by the Affordable Care Act. And our primary goal is to develop, test, and implement new payment and delivery models. I look at us like the R&D arm of CMS. And ultimately, what we want to be able to do is demonstrate one of three scenarios. Either that the models improve quality while keeping costs the same, keep quality the same while reducing costs, or the best case scenario is to improve quality and reduce costs. And if we're able to demonstrate that our models have done this, then they meet the criteria for the Office of the Actuary to certify the model for expansion, and then the Secretary to make a determination that the model is eligible for expansion. So we design and develop all of our models ultimately with this end goal in mind. All of our models are required to have a rigorous independent evaluation. So each model has a pretty robust evaluation completed, and those reports are posted on the website every time they are available, usually on an annual cadence. And we monitor our models throughout the implementation to see and check in on the progress in terms of how we're doing related to meeting those cost and quality targets. I will say that the model development process is very in-depth, looking at both the literature base, the existing gaps and needs. Our Office of the Actuaries are required to develop a cost savings estimate, to look at initial projections of the model, of what the model will achieve in terms of cost savings. We work with a number of our partners around the agency to make sure that, we are testing something that will actually fill a need and close a gap. I think if folks have been monitoring and watching the center's portfolio over the past couple of years, we've really shifted where in the first 10 years, we were really trying a number of different things, playing around and testing different risk scenarios, looking at, both upside and downside risk. And this last batch of models that have come out of the center have really focused more on having providers in the healthcare system put more skin in the game in terms of in terms of downside risk, and taking on more accountability through shared savings arrangements. The cool thing is that I love to talk about is our Medicare diabetes prevention program expanded model is actually one of three expansions that the Innovation Center has been able to achieve over the past 10 years. And that is because the Healthcare Innovation YUSA's award was successful in demonstrating that they improved quality as measured through weight loss and then reduced money. So with that, I will now turn it over to Liz to talk a little bit about the program, and then we'll jump into your questions.
Yes, so good afternoon. My name is Liz Matthews. I'm the Director of the Division of Healthcare Delivery and Prevention and Population Health Group, CMMI, and my division oversees the Medicare Diabetes Prevention Program, as well as the Mayo Heart Cardiovascular Risk Reduction Program. So we can come back and talk about that. As Nina already alluded to, and just to give you a disclaimer here, so this is our traditional standard slide deck. I'm not going to go into detail about each and every slide because we are actually having an enrollment webinar. We're just going to go over this and much more in detail next Thursday. It's on the 27th. And if at the end of this slide, we do have our email box which you guys can email to find out the specific time so that you can enroll for that if you are at all interested, or through facilitators here, I can get you that information. But my team is going to go through again in extreme detail everything you want to know about MDPP enrollment. As Nina already alluded to, not only is this one of the three models expanded from the center, it is the first prevention model expanded from the center, which I think is really important. We established, the national expansion was established through 2 cycles of rulemaking with policies that created a new supplier type, which is the MDPP supplier. So for the first time, not just traditional medical providers like hospitals and physicians, but also community-based entities, churches, we have gyms, we have fitness centers, wellness centers, can also now enroll in Medicare to provide MDPP services. So we have two rounds of rulemaking with the final proposed rule and coming out calendar year 2018, and of course it went into effect the beginning of went into effect January 1st, 2018. So just to quickly to go over some of the slides high level, I guess I'm sure we're all aware here that diabetes definitely negatively impacts health outcomes and carries high costs. Some of the key points that I like to call out on the slide, which I think are always very jarring, are that 1 in 2 adults over the age of 65 actually have pre-diabetes, but only 1 in 7 are aware that they have the condition. Prevalence is high and it's also growing. So we do estimate that we expect diabetes to double by 2050 among adults. And this can lead to a substantial amount of cost. We estimate at $104 billion annually spent for Medicare beneficiaries with diabetes. So MDCP is a structured behavioral health intervention with the goal of preventing the progression of type 2 diabetes in individuals with an indication of prediabetes. So here, what happens is, and our program is up to 2 years, which is different than national DPP. I'll get to a little bit of that later when we respond to some of the questions. But the first year is designed of what we call 4 sessions. So you have your initial sessions, which are the intense weekly sessions, and that's going to happen for 16 weeks. After you get through that phase, you go into the core maintenance sessions, which are going to consist of, it can go down to monthly, that's the requirement, but some suppliers do them bi-weekly, just to do a transition from the weekly to the third phase. And those are going to be interventions delivered by coaches, and the sessions and the curriculum addresses diet, healthy eating activities, physical activity, weight loss, and other lifestyle changes that are going to, again, get the weight loss and maintain, being able to maintain that weight loss. If a beneficiary meets the attendance and weight loss goals for the first year, they then become eligible for the second year of services, which again are only required to be monthly. So as many of you know, so CDC's National Diabetes Prevention Program, this MDPP builds off of that program. And as Nina alluded to earlier, how this model was expanded is that we conducted the DPP model test with the YUSA, which had over approximately 7,800 participants, and it was shown that 45% of them met the 5% weight loss requirement during that test. So due to those results, and also actuaries certifying that the model would have cost savings and that it improved quality of care for beneficiaries, the model was able to be effective. So Medicare pays organizations called MDPP suppliers to furnish these basic interventions to the average beneficiary using CDC's approved National Diabetes Prevention Program curriculum. So the MDPP suppliers, we go over here, can be hospitals, community organizations, churches, clinics, and other kinds of organizations. Of course, they must have full or preliminary CDC DPRP recognition. The reason why that's highlighted, again, is going to go into this in more detail in webinar next week, but that is highlighted. It is an important requirement for our program. We in the beginning, it has slowed down a lot since we have done a lot more of these outreach and education activities. In the beginning, they have a lot of people who our organizations who are applying that only had that did not have the proper recognition. They had what's called pending recognition. So CDC does have 3 types. They have pending, which actually first applied, and then they have preliminary, and then full. So we do have a number of, and again, this will be covered next week, so I'm going to go into detail about this, but we do have a number of educational resources on our website, including a supplier requirements checklist, which can be printed out. We can go through each step we must take in order to apply. Coaches. So the MDPP coaches are ones that actually deliver the session. And these can be employees, contractors, or volunteers of an MDPP supplier. It can be clinical or non-clinical professionals that are trained in the CDC approved curriculum. They have to have a valid NCI, and they must meet full program eligibility requirements as described in our coach eligibility fact sheet, which is again also available on MDPP's website. As far as the beneficiary eligibility requirements go, the beneficiary must have Medicare Part B or C. They must meet 1 of 3 blood tests. And they must have a BMI that is at least 25 or for Asian Americans, 23. already went over this earlier, but again, this slide just goes into detail about the how we set up the studio session. So you have the core session and the core maintenance session, and its beneficiaries again meet the weight loss and attendance milestones. Then they'll be eligible for the ongoing maintenance session, which is the second year of the program. We do like to call out there's no referral required and there's no beneficiary copay. This is what they call our roadmap. So this is the steps to applying to become an MDPP supplier. And again, we highlight here, you must first have your CPC recognition, prepare to enroll as a supplier. We talk about making sure that you have the NPI and also go to our website to look at our enrollment fact sheet and checklist. Once you achieve your full recognition, you can go, once you achieve your recognition, you would have to go to their website and make sure that you have the letter from CDC so that you can include that with your enrollment application. You then go to apply through our online system, which is PAYPO, or to submit a paper application form. One thing I do want to take the time to highlight here is that even if you're an existing Medicare provider, you must re-enroll in MDPP to deliver services. And for the last step of the process of undertaking, you submit claims, and you submit claims to your MAC. We also do a series of billing and claims webinars, so about enrollment and billing claims. So we go into extreme detail about the payment structure, and again, we provide some resources there that we like to add before you on the website. One thing I didn't mention that was on the last slide is that, of course, as you guys know, it came out of the cover practice about the direct. Currently, the way the payment structure works is it's a performance-based payment system where suppliers are eligible to receive payment based on attendance and weight loss milestones. The maximum amount currently is $690. I don't know what the adjustment is for 2020 CPIU, but it's $690 for up to 2 years, and that's the total amount that a supplier can receive per beneficiary. This is our resources slide. So we have some of our key resources. You'll see the third one down is the MDPP website. Another one I like to point out is that on that website, we have a list of MDPP suppliers, and it's an interactive map. You can go, you can see all of the current suppliers and see their contact information. There is about a 2-week delay between just the data feed from when it's finalized and our PAYGO's enrollment system and when it gets to the website. So I ask that providers go and they don't see themselves on yet. And it's outside of the 2 weeks. Definitely email the MDPP resource mailbox team so we can look into that and make sure that you are on the website. Now we will take questions. Nina, you want to start off?
Great. So the first, we received a number of questions related to why CMS is not covering virtual DPP. That ranged from are we looking at different data sources available to reinforce the efficacy of it? Are we anticipating extending coverage, things of that nature? So this gets back to my original points around the Innovation Center and how we determine what is eligible for expansion. So currently, Medicare enrolled MDPP suppliers must furnish services in person, but they are allowed a limited number of virtual makeup sessions. And the decision to not allow payment for virtual DPP was really based in part on the authority that we have, that the Secretary has given under 1115 Big A to expand model tests. So when we tested the DPP in the YUSA, it was only an in-person modality of the program that was tested, not virtual. So we actually strongly considered allowing virtual DPP organizations to participate in the model, but because that original test didn't include virtual services, we were unable to do so. We very much agree that the availability of virtual MDPP services would really support consumer choice and access, particularly for our beneficiaries in rural areas. And because of that, we are actively exploring ways to potentially allow for virtual MDPP services. We're considering to look at options such as a standalone virtual model test, or, looking at whether we could test virtual DPP as part of an existing or future model. But no decision has been made on that at this time. It's something we're working on internally with our leadership. And in order for CMS to be able to really expand the virtual delivery of MDPP, we really do need to find a viable path to be able to test the virtual DPP model in the Medicare population. So that is something that our team is actively working on. We know it is an extreme pain point out there in the DPP and diabetes community. It's something that we are also very passionate about and are working internally to figure out what our next steps to make virtual DPP become a reality. Liz, you want to jump to the next question?
Yes. So we also received a question around why it is a once per lifetime benefit. So the once per lifetime limit on the MDPP services only applies to the expanded model. And the reason I say that is because I want to make sure people understand that if someone, a Medicare beneficiary, could potentially do MDPP and do a separate national DPP program. So it's not a limit on both, just FYI. Yes. And this requirement allows us to capture cleaner data on the beneficiary level to test the model. And following the evaluation of the program, we could potentially consider reviewing this requirement and adjusting the service limits to establish a cycle that is consistent with other preventive care services that are covered by Medicare. But it's just the way we structure the model for a number of reasons, including there was some benefits that we concerned, I think, as well. But again, that's just for this model, and there is potential for a Medicare beneficiary to still use. As far as the next question we received was around enrollment and program challenges. So it would be of value to hear more about the Medicare DPP. Many providers seem to find paperwork to be onerous and the reimbursement to be low. Does CMS have any thoughts on how these issues and low current uptake might be addressed? And would like to hear more about addressing the barriers to the provision of services and the limited uptake. So I would like to start out by saying that noting that we did have a number of challenges initially with enrollment in the beginning, and we were able to do a number of initiatives that we were working with various components throughout the center to boost supply enrollment and ease some of the administrative kinks where we can. So one thing, to speak to some of the things that we are doing around this is that we have a stakeholder engagement and communication outreach plan with our Office of Communication and our regional offices. And what they've been doing is they've been reaching out in areas where we see that we have a higher number of eligible organizations that are not enrolled. Throughout 2018 and again throughout 2018 and 2019, they reached out to do some direct targeting. We also did a number of focus groups to find out why they weren't enrolling and what some of the issues and key pain points were. And we did a lot of work to try to address some of those. Additionally, in areas now where we do have a lot of sites that are enrolled, we're up to almost 800 community locations. So definitely an improvement over the first year. You go to the website and look at the link that we show you again, all the community and administrative locations. So where we have a high number of locations, but we're not seeing a lot of claims come through as servicing beneficiaries, we're also doing direct targeting and marketing to them and say, okay, can we do some geo-targeting to beneficiaries in this area? And we hope to start those efforts this year. And again, that's through our office communication and also working through our regional office contacts. As far as the administrative stuff goes, we have done a lot of work with our Medicare administrative contractors to help facilitate that enrollment process, and also getting the word out there that we have to contact the MAC first. Again, most of our suppliers are organizations who have not dealt with Medicare before, and they, or their existing national DPP organizations who were only grant funded, they didn't have the billing infrastructure, they didn't even know what a MAC was. So through these outreach education activities like the webinars that we've been putting on, we have them frequently, at least quarterly. We also have a YouTube enrollment video. A lot of those efforts have been going on throughout 2018 and 19, and we have seen some significant improvement. Also, the pipeline for suppliers has increased, and we are finally at the point with the other organizations who are in the DPRP. The majority of them are now eligible to participate in MDPP because they have achieved that preliminary recognition. So those are some of the holdups that we saw, we heard, and again, we have been working to address those want to keep those organizations who have not had to go before. But again, we have disability plans webinars. You can contact our teams directly, and also we keep encouraging people to make sure reach out to the MAC, because while we get a lot of inquiries, the MACs are receiving like 11 or 14 a month, because we are tracking all of that data. So it's just us really getting that message out. As far as the pain point around reimbursement and the timing, so we have to, so with that, we would have to do a regulatory change in order to change the reimbursement. I do want to reiterate people that this is an expanded model test, and, we are within our current evaluation period. So, after we have our 5-year evaluation period, and we're looking at, continuing, I think that we continually monitor during the course of the demonstration as well, the models to, see what's working and what's not. We will, do something that comes up all the time, which is like virtual. We are considering the top two things here is volunteer virtual and the payment is slow or the payment structure doesn't work. So those are two things that we are passionate about. And, as we are able to address them, we will work on these two. The next question we received is, as it works with states on Medicaid DPP coverage, how is CMS working to ensure that states understand the value of covering all CDC recognized delivery modalities? So here, the states have flexibility to design their program how they want, as long as it meets the DPRP standards. And CDC is actively working directly with states on DPP coverage. So while states do not have to design their programs to align with MDPP, we do understand that some are. So, for example, Maryland, and we actually work closely with a lot of the states who are wanting to set up their programs for the Medicare side as well. So they care a lot about the Medicaid side. So we work with Maryland, and we go to the DPP network meeting. So they did structure some of their program requirements to pass the Medicare, but again, their CPP has a group of people working directly with them on that. So I think what the question is getting at is, are the states going to cover virtual? States can cover for the Medicaid population. They can cover virtual. That's right. I think that would get the answer to the question. The next question is, can there be better alignment between CMS and CDC requirements for pre-diabetes in terms of payment, quality assurance, and managing CDC? And can there be a better phasing of reimbursement? So I addressed the reimbursement. We're kind of, we have the reimbursement structure that we have for now. But as far as the alignment, the one thing I wanted to point out and do the presentation is that, again, we're on the phone weekly, if not daily, with our CDC counterparts. So they run the Diabetes Prevention Recognition Program, where they set the quality assurance standards that organizations must meet in order to be recognized. Medicare is one of the many payers nationwide for the program. And as a condition to become a Medicare supplier, we have to impose certain requirements that are different from national DPP. And we understand that it causes confusion for organizations to participate in both the national DPP and MDPP. However, we do work closely with CDC to try to minimize some of these issues and make it a more efficient process as we can. So, for example, the CDC is coming out with they make some revisions like to the modalities and to specify which modalities are which, and have different org codes and also application processing to ensure that they are issuing the recognition letters in a way that can be accepted by the MAC and CAPO that doesn't cause confusion. So all of those are, we directly heard feedback from suppliers, and then we work directly with our counterparts to make sure that we, again, are trying to use some of those pain points, but to the extent that we can, because this is a Medicare program, and again, we created a new supplier type for the first time, so they have to be held accountable to the high risk standards of training. So there are a few things that we know do differ from the DPRP requirements, but it's just the nature of being a Medicare.
Bill, let us turn it back over to you if there are any additional questions.
Sure. Thank you, Nina and Liz. Are there additional questions from anyone on the commission? What proportion of the NDPP providers also provide the DPP for Medicare beneficiaries?
So I believe right now there are about 800 and National Diabetes Prevention Program organizations who are eligible to enroll in MDTP, but we have 192 who are provided or enrolled in MDTP. So the answer is 192.
So about a quarter of them then. And what are the barriers? The billing or the you mentioned that. What do you think the primary barriers are?
So the primary barriers are one, the billing, well, the enrollment process in general, because you have to enroll to become a Medicare supplier and you have to do that Kinko. Even for organizations who, this was surprising stuff, even for organizations who are already Medicare providers, doing it again and getting the level and clearances that they need to go through the administrative process was burdensome. So that's one thing. Second, the billing and claims infrastructure, and some people you need a third-party biller, or they need the software to submit the claim to the particular MAC, and the MAC uses the software, CMS doesn't provide the standard one. Also, just the cost. To be honest, the cost of administering the program, the coaches, you have to be trained, the CDC training is not free, so you have a lot of upfront costs, and as you see, most of the time, you're not going to start receiving payment until you know well into start delivering your session. So those are the main and then not having virtual, those are the main barriers that we hear.
Yeah, this is Ann. Just to quickly clarify, it's not CDC training. We don't charge. It's up to the organization, to our training organizations. CDC doesn't charge anybody anything.
Thanks for that clarification, Ann.
And is it difficult for lay providers to get NPI numbers? What's involved in that?
No, so we talk about that specifically in detail on our enrollment fact sheet and checklist, and the webinar is going to do next. So no, you go to an MPAS website, so you go to the website, and then they fill out that form and they receive the NPI.
Good, well, thank you both very much, and thanks for taking all of our questions on. I think you did a great job in addressing them.
Thank you so much. We appreciate it.
Thanks for sending them.
I want to thank all of the presenters, and again, thank Barry Marks for putting together such a wonderful and comprehensive overview of the various CMS programs. I think it's really been fantastic. It looks like we're on the agenda up to oral public comments. Linda or Clydette, are there any people scheduled?
Yes, we have 4 people scheduled to make comments. I believe Larry McNeely is up first.
Yes, is this Larry?
Yes, indeed. This is Larry McNeely. I'm Director of Public Policy with the American Diabetes Association. Are you ready for me?
Yes, Larry, go ahead. We have 3 minutes. At the 15-second mark, you'll hear an alarm, and then the operator will mute your line at the 3-minute mark. So you may go ahead and talk.
Very good. So much gratitude I think we'd like to express to the staff of and the members of the commission, as well as the folks presenting today. But on to the details. We wanted to particularly express our appreciation for the Commission's attention to health equity with respect to priority populations, both at CMS and the previous work of the Commission, as well as more broadly the focus on social determinants of health for all. As just one example of such a determinant, from the ADA's perspective, food insecurity, we know it's associated with increased diabetes, type 2 diabetes risk, and in those with diabetes with poor adherence and poor glycemic control. We know FI is more prevalent in African American, Latino populations, low-income households, homes headed by a single mother. Leveraging effective USDA nutrition programs like SNAP, school meals, summer feeding, and WIC is key to any diabetes control and prevention strategy, in addition to all the clinical work. So we appreciate the focus there. I did want to also underline a few points included in our response to the Commission's request for comments in the Federal Register. One, progress on urgently on Medicare DPP, particularly on virtual access and access to Medicare DPP in priority populations, is urgently needed if we're going to realize the promise of this intervention and the possibility of coverage for it. We're concerned here with where we stand today. As much as we've enjoyed and appreciated working with CMS and CDC on this, we also have specific steps that we outlined regarding DSMES in our letter. And I should say that diabetes management requires a combination of provider care, tools, education, medication. If any of one of those are disrupted, if you can't afford them, that's a problem. That's both a social determinant and an access barrier. It's why coverage and affordability of actual service under that coverage is important. That's why, this commission should consider broader access to Medicaid and lowering cost sharing for essential services as a piece of what you end up recommending. A final point on type 2 diabetes and prediabetes screening. We know there are recommendations, evidence-based. There's a huge gap between those recommendations and real-world practice. We've got to close that gap. It's vital to bending the curve in diabetes. I believe my 3 minutes are up. Thank you so much.
Thank you very much for your comments.
So next we have Charlene Dorsey.
Good afternoon. Hi, I'm Charlene Dorsey. I'm a registered dietitian nutritionist and a certified diabetes care and education specialist. And today I'm speaking on behalf of the Academy of Nutrition and Dietetics. The Academy recently submitted comments to the Commission on policies, promising practices and limitations and gaps for consideration by the Commission. We request that the Commission consider two promising practices. First is access to medical nutrition therapy services for Medicare participants with pre-diabetes. Currently, Medicare only covers MNT for diabetes and renal disease, hampering the ability of the healthcare system to intervene early. MNT for pre-diabetes is recommended by the American Association of Clinical Endocrinologists, the American College of Endocrinology, and the American Diabetes Association. Second, we request that the Commission advise HHS to recognize intensive behavioral therapy, or IBT, for obesity as within the scope of registered dietitian nutritionists. Currently, only primary care providers in a primary care setting can bill Medicare directly for this service. According to the National Academies of Sciences, Engineering, and Medicine, quote, the registered dietitian is currently the single identifiable group of healthcare professionals with standardized education, clinical training, continuing education, and national credentialing requirements necessary to be directly reimbursed as a provider of nutrition therapy, end quote. We also identified many limitations and gaps in coverage related to diabetes self-management training, medical nutrition therapy, intensive behavioral therapy, and telehealth. As mentioned, Medicare does not cover MNT for prediabetes, and the same restriction exists for most other chronic diseases as well. Additionally, while both diabetes self-management training and medical nutrition therapy are both covered for patients with diabetes, and Medicare has acknowledged that the services are distinct, cannot be delivered on the same day. Other limitations that reduce beneficiary access to DSMT, MNT, and IBT services include diagnostic lab eligibility criteria that are not aligned with clinical guidelines, limitations on referral sources that do not reflect the way that primary care is provided in America, copayment and deductibles, inadequate annual coverage levels, and limited sites of services in the case of DSMT. And lastly, CMS's current telehealth policies are antiquated and do not adequately address the needs of Medicare patients, providers, or the Medicare program itself. Expanding the availability of telehealth services will assist Medicare beneficiaries living in urban and suburban areas who have limited mobility and transportation issues. Thank you for considering the Academy of Nutrition and Dietetics comments and recommendations. Academy staff and members remain available to the Commission as a resource throughout your deliberations.
Thank you very much.
Next we have Frank Harrington.
Hello, my name is Frank Harrington. I'm the Director of Reimbursement and Regulatory Affairs for the American Association of Nurse Practitioners. On behalf of the more than 100,000 members of AANP and the over 270,000 MPs across the nation, we appreciate the opportunity to provide the following comments. We commend the Commission for its work, and our comments are related to gaps in the Medicare and Medicaid programs that can be closed in order to improve care for patients with insulin-related disorders. We appreciate your consideration of these comments and look forward to further work with the Commission on removing barriers to patient care. NPs are advanced practice registered nurses prepared at the master's or doctoral level to provide primary, acute, chronic, and specialty care to patients of all ages and walks of life. NPs practice in nearly every healthcare setting, hold prescriptive authority in all 50 states and DC to perform more than 1 billion patient visits annually. Based on Medicare's data, as of 2018, there were 146,000 NPs billing for Medicare services, making NPs the largest and fastest growing Medicare designated provider specialty, and 36% of Medicare patients receive billable services from an NP. NPs comprise 1/4 of the primary care workforce, with that percentage growing annually, and they comprise an even larger portion in rural and underserved areas. Despite decades of evidence showing that NPs provide high-quality, cost-effective healthcare, NPs are still constrained by outdated statutes and regulations within the Medicare and Medicaid programs that are more restrictive than state law. These barriers deprive patients of their provider of choice, reduce access to medically necessary treatment, and delay care. As the Commission evaluates federal policies that would improve diabetes outcomes and close gaps in care, we respectfully request that you recommend that the Secretary of Health and Human Services and Congress remove the following barriers for NPs and their patients. Patient access to therapeutic use for treatment of diabetes. NPs are authorized to order DME for Medicare beneficiaries. However, an NP treating a Medicare patient with diabetes must locate a physician to certify the patient's need for therapeutic use. An NP's patient must undergo the following redundant multi-step process to obtain their necessary treatment. The NP who is treating the patient with diabetes determines that the patient needs therapeutic use. Then the NP must send the patient to a physician to make the same determination. The physician then refers the patient to a podiatrist or other qualified individual to fit and furnish the shoes. Specialized therapeutic footwear for high-risk patients with diabetes, including those with severe neuropathy, foot deformities, or history of amputation, is recommended by the ADA. Requiring a physician to certify that a patient requires therapeutic shoes after the patient's NP has already made that determination delays access to a treatment that has been shown to reduce ulcerations and resulting complications, improve quality of life, and reduce healthcare spending. We encourage the Commission to recommend removing this barrier to care. Medicare and Medicaid home healthcare services. Under the Medicare and Medicaid home healthcare benefits, an NP must find a physician to document the face-to-face assessment and have a physician certify and recertify the plan of care. NPs cannot make necessary adjustments to medication or treatment without obtaining a physician's signature, putting patients at risk for avoidable complications. We also encourage the Commission to recommend removing these requirements for Medicare and Medicaid beneficiaries. My time is closing, but I would also note that we have similar barriers for referring patients for medical nutrition therapy and ordering cardiac and pulmonary rehabilitation, both of which are important to this population. We have all this in our written comments in response to the RFI, and we thank you again for the time this afternoon to provide these comments and look forward to working together.
Great. Thank you very much.
Next, we have Hannah Martin.
Hi, this is Hannah Martin. I'm the Director of Legislative and Government Affairs at the Academy of Nutrition and Dietetics. You already heard our comments from our member, Charlene Dorsey, who practices in the field. So I do not have anything to add at this time other than to reiterate our availability to the Commission, as well as our deep thanks for the Commission for all of their studious work on this issue.
Fantastic. Thank you very much.
Those are all the public comments.
Good. So I want to thank each of the folks who provided comments. We will certainly review their written suggestions as well and include them in the deliberations of the Commission. Good. And I guess I will turn it over to Linda or Clydette to close.
Thanks, Bill. I believe that's, this is Linda. I believe it's my job to adjourn this meeting until next time. Have a good evening.
Thanks, everyone.